way, and the main culprit is the estrogen. It is an estrogen dependent tumor and it is maintained by the estrogen only. So if they have said what are the cells responsible for the formation of pulmonary benign metastasizing leiomyoma, may be derived from a low-grade tumor. Cells dislodged from the tumor at the time of myomectomy or hysterectomy. This patient had undergone myomectomy 10 years back, then again the second surgery. Proliferation of lung smooth muscle and simultaneous independent development of leiomyomas at multiple sites, or metastasis from uterus or unknown sites. So these are the well accepted theories for the clinicians and pathologists to make a diagnosis. That is how they have coined this term, pulmonary benign metastasizing leiomyoma. Obviously it metastasizes, but it is not the real. 5 cases from one city, that paper, yeah. So, and Professor Venu for his exhaustive, because Venu is someone who will not miss a malignancy, So I usually send it to him for all the true-cut biopsies and differential diagnosis. And so Dr. Suraj and Dr. Venu are classmates, so they have decided to destroy me today. And they have agreed that, this is a very rare case, and he, despite being in an RCC, he did not see a case. Seeing hundreds of pulmonary Mets, he did not see a case. So that makes us case discussion very fruitful, and I once again congratulate the organizers, the scientific committee, Dr. Vivek, Dr. Arjun, Sanjeev Nair, and the rest of the entire team. And I hope we will have wonderful sessions. A lot of good sessions are there, so please make sure that you all attend it, then enjoy in the evening at the beachside. Thank you so much.
and rapid taper over 4 months. So this was the first RCT. Again, all of them are done by the same team. So Dr. Ritesh sir, he has compared these 2 regimens, the high dose and the medium dose, and what they had looked at is not the response but the chance of exacerbations. What they have seen is that both the doses had equal response rates, and also the time to exacerbation was not different. So which means that you don't have to give very high doses. A 0.5 milligram per kg per day and tapered over 4 months is as good as a high dose. So this has changed our practice, and from then we have been using 0.5 mg per kg as the initial dose. Second, this is a study which compared oral steroids with itraconazole for treatment naive ABPA. All of these are on treatment naive ABPA, not relapsed ABPA. Again, when they have randomized people and looked at it, here they looked at the response rates. So how do you define response? A 75% reduction in symptoms, at least a 50% reduction in radiological opacities, and a 25% reduction in IgE levels. It is not normalization of IgE, 25% reduction in IgE levels. If you see the primary outcomes, here if you see the picture is of the IgE levels. So oral steroids versus plain itraconazole, there was no difference in the reduction of IgE levels, same. Then the primary outcomes also, if you see the steroid group, 100% response at 6 weeks. Itraconazole 88%, but by the end of 3 months, both are similar. So what we can say from this study is that ABPA responds very well to steroids. It also responds very well to oral itraconazole. So this RCT has actually shown that in people who cannot tolerate steroids, who have side effects to steroids, you can give a oral itraconazole. This is 200 milligrams twice daily taken with food. For people who cannot tolerate steroids, oral azole monotherapy, itraconazole or voriconazole can be a reasonable first line choice. 3, for people who are at a high risk of exacerbations, high eosinophil counts, significant burden of bronchiectasis, probably you are not wrong in giving upfront combination of OCS plus azoles. So the 4 trials, each with a different message, each of which has changed our approach to the management of disease. Now what is new in the treatment of ABPA is the upcoming role of nebulized therapies. There are 2 trials on nebulized amphotericin B, 1 trial ongoing on inhaled itraconazole. So again, these 2 trials did not aim at getting a response. So response we are anyway getting 100%. So these both trials looked at whether maintaining an antifungal nebulized will decrease the chance of exacerbation. So Nebulam study is one RCT which is not from India. So they have looked after getting a response by the initial induction. They gave, this is very, very important. So now what is it that with plain steroids, plain antifungal, you're getting a 100% response. So what more do you want? But the problem with all these things is that the high relapse rate. After you stop therapy, up to 40 to 50% of these ABPA patients will have an exacerbation in the next 3 years. So you have got 100% response rates. Now you want to decrease the chance of future exacerbation. So what can you do for that? So this is one study which looked whether combined.
And if so, why should you have this knowledge? How is this going to change your practice? Way back in 1915, when Rohrer looked at the resistance across the different portions of the airways, he made a very clear statement that as the airways become smaller and smaller from generation 0 to 23, the lumen becomes smaller and smaller, and therefore the resistance is going to become bigger and bigger. But natural, isn't it? As the luminal radius becomes smaller, the resistance increases. And he said that the highest resistance in the airways, we would find it in the small airways. Sounded very logical at that time in 1915, but in 1965, Sir Malcolm Green from the Imperial College in London did a very simple experiment and showed that the resistance in the small airways is exactly the opposite. In fact, the small airways contribute to a very small proportion of the total respiratory resistance. And the logic that he gave was, although when air passes through a narrow tube, the resistance increases, but then you have those 100,000 such tubes that generate from that one single tube called as a trachea. So it is this large surface area that actually negates the significant increase in resistance in the small airways. And in fact, Sir Malcolm Green actually called this as a silent zone of the lung. He thoughts right from the chest wall to the nose, that contributes to 66% of the total respiratory resistance. And the remaining 7% comes from the distension of the alveolar walls that is required. Now the reason why we need to appreciate this, so until more than 50% of these small airways get affected or damaged, you will not start appreciating the symptoms that are associated with small airways obstruction. They are defined as those airways which have an intraluminal diameter of less than 2 millimeters. They obviously have no cartilage, but they have smooth muscles. And because they have smooth muscles, they have access to getting treated with cholinergic and anticholinergic and bronchodilator drugs. In the patency of these small airways. Now here you can see radiographic imaging of particle deposition of different sizes. A are the large airways, B are the medium-sized airways, and C are the small-sized airways. So if you take particles which are around 6 microns, they will reach only the A portion of the airways, as you can see in that radiographic scintigraphy. Those particles between 2 to 5 microns will reach the B portion, and only those particles which are less than 1.8 microns will reach the C portion. Now the traditional inhaled medications that we have for asthma, budesonide, formoterol, salmeterol, fluticasone, made by any company, they all have particles between 2 to 5 microns. And therefore they do not have the capability of reaching the small airway component in sufficient numbers. If for animal dung smoke or wood smoke or kerosene smoke or coal smoke, look at the particle sizes. The particle sizes itself will tell you where the damage is going to occur if you inhale them. That if you see a patient in your clinic whose asthma is not getting well controlled, look at these possibilities. Is the patient using the inhalers correctly? Is the patient adhering to the treatment? Are there psychological factors that are contributing to poor asthma control? And are there environmental triggers that are constantly giving rise to spasm? But other than that, also look for one more point, and that is, does this patient have sad asthma? So in your clinic, if you see these patients, always think of the possibility of this patient having sad asthma. Now the same Atlantis study, these patients were followed over a period of 1 year, and they looked for asthma control versus asthma exacerbations. And not so surprisingly, they exactly found what I just described in the previous slide. And again, that last purple paragraph box over here, SAD should be added to the list of risk factors of poor asthma outcomes. Now that was in the clinic. What about in the community setting? So this was a very large study conducted in China in more than 50,000 people randomly selected from the community. But this time they used spirometry to define small airways obstruction using the FEF 25 to 75% predicted values, which have to be less than 65%. And what they found exactly was the same. As your age increases, the proportion of asthmatics having small airways dysfunction increases significantly.
Because Professor Salvi had to go for another talk, I will have two questions to you or from the audience also if they want to ask. You said SAD asthma, the incidence is almost, prevalence is almost 50%. But in practice, we do not see that much of non-responsiveness. 50%, is it a little high for all asthmas? Whether they are, you said that asthma people, the small airway disease is involved in more than 50% of
more
cases.
Than 50%. And as the severity of the asthma increases, the proportion of individuals having small airways disease increases significantly. So severe asthmatics, a large proportion of them will be having small airways dysfunction. So I think it's important to appreciate that because so all the severe asthmatics are probably because they have small airways obstruction. And we're not treating that component with the traditional drugs that we're using.
Another question is ultrafine particles, what's the size of the particles, sir?
So the particle size should be between 0.8 to 1.3 microns, and that you can get only with cyclosonide and the beclomethosone HFA formulation.
But earlier we were thinking that it is when it is very small, it just floats in the air and comes back. So will it get deposited in the airways? Because the classical teaching was that. Because yes. No gravitation, sedimentation and impaction was the
You're
factors.
Very right. So maybe for ultrafine particles, the way you take the inhaler should be different. So take a slow and deep inhalation and hold your breath for as long as possible. Okay. Because that is going to ensure that it gets deposited in the smaller airways.
Any question from panelists you want to ask? Or from the delegates?
Thank you, sir. As you have mentioned, many of the asthmatics who are not controlled, with your usual medication, you have to think about small airway dysfunction, I think. Because majority of the patient with asthmatics, when the severity, according to GINA guidelines, when the severity increases, according to you, the chance of small airway dysfunction, significant small airway dysfunction, is going on increasing. The prevalence is going on increasing. It's close to 80% in stage 5. So we have to think about that small airway dysfunction in all patients, I think.
Absolutely.
Effect of the molecule like a beclomethosone that would go and deposit in airways which is smaller than 2 millimeter, and these these fine particles around less than 2 micrometer, again 1.8 to 2 micrometer. Could you enhance it by using a spacer?
No. So
no.
The key criteria is the particle size.
Okay. So it doesn't matter whether the only thing is it's a class effect of the molecule that you use.
Absolutely.
Thank you so much. Right.
Clinically relevant treatable traits in asthma. This is the beautiful Mysore Palace. I have no conflicts. Now, the term treatable traits was coined somewhere in 2016 by Augusti, and this is looking at the precision medicine approach, looking at all the various characteristics that are there, including the psychosocial characteristics which a lot of clinicians don't actually look at. And a treatable trait is a recognizable phenotypic or an endotypic characteristic that can be assessed. There is a diagnostic tool, and it can be successfully targeted by therapy to improve clinical outcome. It is free from the traditional diagnostic label. We label asthma, COPD, ACO, but we find a lot of characteristics that go across all these. So when you start treating with treatable trait, it becomes diagnostic labels are not there. It becomes agnostic. Now there are three special groups. One is the pulmonary treatable trait, extrapulmonary treatable trait, behavioral treatable trait. These are the three main groups that are there. In the usual care, if you see for all the guidelines and all that, we have a stepwise approach, but it needs more time. Some patients are poorly controlled despite all our treatment. Escalation of steroids in some patients, they may not have a good effect, but it starts having side effects. And of course, we have one size fits all, we have GINA grading, and then we put the patient on that treatment. Now, if you look at the treatable traits, for example, if you were to look at the different types of patients if you have, and you can group them into phenotypes, but actually if you look at what we see in the clinic is in the last group, like, where we have the clinical traits, but that each patient, if you see individually, may have multiple phenotypes in each patient. So that is what we are not looking at currently, and that is what treatable trait is all about. It takes the whole patient into account. We have the key factors to identify which patient needs which approach, and then look at an individual management plan. Now, how common is this? This is the novelty study, number 11,000 subjects in 19 countries. It's a busy slide, so I'm just summarizing. More than 40% will show non-reversible airflow obstruction. A lot of them will use indoor use of biomass coal, especially even in the Western countries, they use a lot of it. 30 to 40% will have frequent productive cough, allergic sinusitis, T2 high, occupational exposures, frequent reliever use. These are some of the common treatable traits that have been identified. If you take each patient, for example, if you take a patient with asthma, on an average they will have about 4.6 treatable traits, COPD slightly higher. Asthma COPD has the most with 6.4 treatable traits per patient. So, this is a slide that summarizes the three groups, and of course the first one total will give you all of those. And if you look at the quality of life, as the number of treatable traits increases, quality of life becomes poor. And even when you subgroup them as severe and mild to moderate, the more severe the disease, the higher the number of treatable traits that are prevalent. And as the treatable trait increases, or there are specific treatable traits that can increase the risk of asthma acute exacerbations. And they always occur together. So as you see how we have the three nodes, that is pulmonary, extrapulmonary, behavioral, and the line, the thickness of the line will tell you how common it is, and then you have all the treatable traits together, that we will see each one of them when we come to the treatment. And then you find that there is an absolutely close interaction between all of these. It's a very, very complex patient that we have. Glucocorticoid receptor beta doesn't go into the nucleus, doesn't bind to the GRE, and therefore anti-inflammatory cytokines do not come. This leads to steroid resistance. Airway remodeling, we have already talked about the phenotypes that are associated with airway remodeling. It could also be small lungs. That means 36 of our subjects could have had small lungs. The other point I want to share, this is in the general population. We have screened about 5,000 plus subjects, 3,500 subjects now. We have their lung function data. This is children between 11 to 14 years of age. And we find that more than 50% of the children, this is spread across Mysore, Bangalore, Bombay and Delhi, 50% of them actually have low lung functions, less than 80%. We are looking at the airway obstruction, at the air pollution and the impact on these subjects. And Delhi and Bangalore, as you can see, had the maximum number of subjects. We are looking at air pollution and exposure to subjects who are highly resistant, and also those who are highly susceptible. Finally, this is a resource tool that is from Australia and gives you a lot of information on these treatable traits. It could be worth looking at. Thank you very much.
For all, and each has to be seen specifically, and it has to be tailored, and the shed size is not the same for all. And now we will have a 10 minutes discussion, and I will ask the same last one. I'll start from the last one itself. Mani, what do you think? What are the clinically treatable traits of asthma which is usually missed in your day-to-day practice?
Respected chair, speakers and respected seniors. Though we are having very good guidelines for treating asthma, step care with ICS, and we are in the era of genomics, metagenomics, transcriptomics and all. Still we are missing a lot of patients. It's not well controlled. As my friend Dr. Mahesh rightly said about some treatable traits are missing right from the beginning. Though especially Sandeep sir said about SAD asthma, though especially is presented as cough variant, though may not able to control fully. Some of the patient may be referred to as cough is not responded to any kind of treatment. They have taken HRCT and all. Probably some lesions are there like the signs of small airway dysfunction, air trapping and all. That is coming to us. So if the case is come to us, we can make diagnosis of SAD asthma. Otherwise, we treat as interstitial, early interstitial lung disease like that and all, or maybe obstructive airway disease. That you have to detect earlier. That is one point. Second point is, especially I am coming to the behavioral triad. Though we are discussing things many years, but still it is very, very important to looking into methodology of using the inhalers. Though once we are studied the patient and bystanders regarding the methodology, especially using with the spacer, still a majority of patient may not be fully adhere to that methodology. And third thing is selection of molecules, and SAD asthma and also is fine molecule we have to select cyclosinide or bectamethasone. That is one point. Second point, again coming to the extrapulmonary triad we look into, especially the area of anxiety and depression. Though how many percentage of patients we are addressing. Though these triads are very few numbers in general population, but asthma is coming to pulmonologists, the number is very high. Though the SAD asthma also is very high, because they are not responded to periphery or by the physicians. That's why the patient is referred to us. So look at that number is very high. That you have to address. The same way, anxiety and depression you have to address very properly by ourselves or by the getting consultation with the psychologist. Third thing is especially laryngopharyngeal reflex is another problem, and GERD, though they may not be properly addressed. And fifth thing is what I noticed is aspirin-induced respiratory diseases, especially asthmatics. Though patient might have different disease, especially some cardiac problem is there by the angina, coronary disease and all. Cardiologist given a prescription. We pulmonologists, okay, it's a very reputed cardiologist. We are not looking into the prescription of cardiologist. That is what is practically happening. So we will not look into what is aspirin is present or not. We are simply looking at our prescription. Have a look at that. If it is there, can have a discussion with the cardiologist. Better change to some other antiplatelets. That brings a lot of changes in the response to asthma. Then other one is, as you rightly said about obesity, it's also not well addressed. These are the very important. Still again, we can look at the persistent exposure to triggers. Still though we are discussing last many years, more than 50 years, but still it is there. And either depending, not on, based on economic status, even the poor.
There are also particles below that size.
Okay.
So you take any inhaler, a small amount may still reach the small level.
Of course.
If the small airway inflammation is minimal, that itself is sufficient to take care of it. So you will find that 50-60% of the patients you start inhalers, they will get better in spite of them having small airway inflammation because it is minimal and that dose is sufficient. But a certain percent will not get, and then you will have to move into. Before we start thinking of severe asthma, now it is my practice, though it is not in the guidelines, I will move into a small airway particle size inhaler. And before we had turbohaler only, now you have other diseases.
Okay.
I mean other devices as well that can reach there. And you will find at least 15 to 20% will suddenly respond once you switch over to these.
Switch over the
These may have lesser medium large airway inflammation and greater small airway inflammation. So they will need more of that. And the large medium small airway inflammation is there through and through.
Yes.
There is some data to even say now there is a little bit of alveolitis also in asthma. So So these are the issues.
These are combinations. Thank you. I would like to ask Nagarjuna, because in the context with tuberculosis, and now those criteria has been added as risk factors for ABPA. But how important do you think in your registry? You know,
So I think very
only asthma and cystic
or
fibrosis.
cystic fibrosis are will predispose to
Yes.
ABPA. But the current data says that any bronchiectasis, not necessarily CF bronchiectasis, in fact COPD also is a risk factor for ABPA. In fact, in the next ISHAM guidelines, where we had a meeting recently,
Because we have to,
yes, so in that, in the predisposing factors, now we are trying to add COPD and bronchiectasis also as a predisposing factor. I think it is very correctly said, sir. So we should come out of the fact that only asthma, or only cystic fibrosis can predispose to ABPA. Basically, any structural lung
damage
disease,
to
yes,
the lung.
can,
Thank you.
can definitely
Yes.
predispose.
Thank you very much. Dr. Sonia, what do you think? Is antifungal therapy?
SAFS is actually a subgroup of asthma in which the patients are excessively reacting to inhaled fungal spores. There are very few studies regarding this, and it has shown that antifungals have reduced the exacerbation rates, reduced the fungal burden, and also increased response to glucocorticosteroids. But we do not yet have the optimum duration of antifungals which have to be given to achieve such a result. And also it's a phenotype, and we do not know if all patients with SAFS really need antifungals. It needs further research. Thank you.
What do you think, Nagarjuna, Mahesh? We have 1 minute.
You know, the main issue with ABPA, I talked to Ritesh also. When you talk of ABPA, the main problem is type 1, type 3, type 4. But every diagnostic criteria has only type 1. Right? So I said immune complex activation is something we need to have a diagnostic mortality. Type 4, we need to have a diagnostic mortality. I think that will be useful.
Nagarjuna, you want to add?
So
1 minute.
regarding
One question from, sorry to, because
SAFS,
Nagarjuna,
Like you can send your patient for a bone mineral density score and you can treat. You need not send the patient to orthopedicians, number one. You can give a dietary prescription. You probably don't need a dietitian. That is number two. Number three is the major complaints of most of this patient is mucus stucking in the chest. So the muco-obstructive lung disease in COPD. So the mucus hypersecretion management. These are the simple treatable traits which you can treat from your prescription table. Thank you so much. Thank you.
Nagarjuna, you want to, you would say
I was just talking
half a
about,
minute.
So, you know, the main issue with ABPA, I talked to Ritesh also. When you talk of ABPA, the main problem is type 1, type 3, type 4. But every diagnostic criteria has only type 1. Right? So I said immune complex activation is something we need to have a diagnostic mortality. Type 4, we need to have a diagnostic mortality. I think that will be useful.
Nagarjuna, you want to add?
So
1 minute.
regarding
One question from, sorry to, because
SAFS,
Nagarjuna,
day in and day out. We attend so many conferences, but APCCM conference is the one and only conference where we always see a full hall. We should always laud the organizers. Over the years, more than 25 years now, almost all conferences of APCCM which I have attended, I have always seen a full hall. But in majority of the other conferences, halls are sometimes after the second or third day, the audience are very less. So it is time for us to think how we can make people interested to attend the conferences and learn something new. For this, basically, we need to know why do people attend conferences? Because unless otherwise we cater to their needs, we will never be successful. Most importantly, yes, definitely, when invited as faculty, definitely people will come. Yes, the youngsters always look for opportunities to learn, especially the postgraduate students. So they need to learn, so they would like to attend. And most importantly, to collaborate with others, improve the science, and networking is very important, especially for the youngsters in the beginning of their careers. And the most often forgotten aspect is, yes, for busy practitioners, it is the place where we can meet our friends, the long-time colleagues, and meet friends and socialize. And of course, last but not the least, we do take time off from our busy schedule for some leisure activity in addition to the conference per se. The scientific committee should know who are the target audience. So the scientific program should be definitely should cater to the needs of the attendees, and we need to get the feedback at the end of the day from the participants to see whether these objectives have been fulfilled. And once we get the feedback, we need to evaluate so that we can improve on further. Well, in a conference, it's very important to generate new ideas, new objectives, and some new resolutions also need to be generated. And we may have to generate some new data, opportunities, especially for the youngsters, and the collaboration with the national and the international faculties when it is a national level conference.
Depends on the time. If it is late at night, the other question that looms in is that acute dyspneic patient, it turns out to be a COPD exacerbation, then gently write a letter, dear sir, please take over this patient, this is not a case of cardiac dyspnea. So basically, either we rule in or we rule out cardiac dyspnea, and that is very important for both the respiratory physician and the cardiologist. Now, if we look into the diagnosis of heart failure in that acutely dyspneic patient, right? First, we look at clinical, of course, assess the patient history, physical examination. We look at imaging, very vital. In fact, imaging has become such an important role that people tend to forget that there is clinical medicine. And of course, third, biomarkers. So clinical imaging and biomarker gives us an impression of are we dealing with a cardiac cause of dyspnea, right? And when we talk about clinical, we go back and ask, do you have history of effort intolerance in the past? Do you have a cardiac history? Do you have PND or orthopnea in the past? And physical findings like, does this patient have pedal edema? For imaging, traditionally, we would look at an X-ray or an echocardiogram to look at the left ventricular function that would tell us, is this a cardiac dyspnea or is this respiratory? And finally, of course, today we have very strong, very sensitive biomarkers, we'll talk about them, like the NT-proBNP, which is today available to every clinician and most major hospitals. Now, with the clinical imaging biomarker in background, very rarely today you see good journals bring out studies on clinical medicine, right? This came in JAMA about a decade back, which talked about, look at that, exactly what we are talking about. The dyspneic patient in the ER, does he have congestive heart failure? The very question that we are trying to answer, right? This dyspneic patient, does he have congestive heart failure? This is a beautiful paper. Postgraduates, if anyone are there, this is in JAMA. Do find it out. This is written by Charles Wong and Mark Fitzgerald. It comes from Vancouver Hospital, City Hospital under the University of British Columbia. Very beautiful paper. Now, this paper looks at the clinical likelihood ratio, look at that, the clinical likelihood ratio of this dyspneic patient having a heart failure. So we're looking at likelihood ratio of this dyspneic patient having heart failure. And the first is past history of heart failure. If there's a clear past history of heart failure, the LR, the likelihood ratio is 5.8. If there is history of clear proximal nocturnal dyspnea, it is 2.6. If there's a third heart sound, it is 11.9. And if it is an AFib, you have 3.8, right? So these four stood out as the four major clinical factors which tell us that this patient has a cardiac dyspnea and not respiratory dyspnea. So what are they? Past history of heart failure, PND, a loud, clear gallop, S3, and atrial fibrillation. They increase the likelihood ratio that this is a cardiac dyspnea. And also, don't forget that in cardiac dyspnea, there might be precipitating features. For example, the first one is an IHD, a massive MI. If the patient's ECG shows a massive MI, you know that it's cardiac dyspnea. If the patient has major arrhythmias, like a VT or an AFib, it is the precipitating factor for the cardiac dyspnea. If the patient has accelerated hypertension, you are thinking in the line of cardiac dyspnea. So apart from those very strong points that gives us a lead that there's in cardiac dyspnea, like past history of heart failure, PND, loud gallop, AFib, these four needs to be looked into. Now if we go into a little bit of hemodynamic, when the heart fails, right? When the heart fails, you see there's lack of perfusion. So the heart doesn't pump, you don't get sufficient blood going to the organs, right? At the same time, you get backward congestion. We know this congestion and the perfusion defect forms the basics of heart failure, right? So if we look into congestion, apart from obviously the patient is congested, is dyspneic, apart from dyspnea, we look at JVP, the hepatojugular reflux, edema, hepatomegaly, and stuff like that. We look at reduced perfusion, like is he in shock, right? Now the point is, apart from shock, we need to look at other features of hyperperfusion. For example, a systolic blood pressure of less than 100, a low pulse pressure. Now this is important. A patient who has a low blood pressure of 110 by 90, 110 by 100, very short pulse pressure, is likely to have a cardiac dyspnea. Cardiac index of less than 2.2 liters, cold extremities, confusion, drowsiness, small and large. Electrical alternance, so if there are postgraduates here, classical electrical alternance in the ECG tells you that there's cardiac tamponade and the patient needs to quickly have the fluid, pericardial fluid drained out. Pericardial effusion with tamponade, right? Now we put the point there and take a card there and we look at IVC. Every resident should learn how to look at the IVC because that tells you about congestion, right? The IVC looks like this and we measure the IVC, that is how it looks like. Take a measurement of IVC and we should be aware about what IVC tells us. So very clear, IVC normal dimensions are 1.5 to 2.5 centimeters, right? And should have a 50% collapse. That is the normal range. So that tells us that the volume status of the patient is normal. In contrast, the patient has got IVC size less than 1.5, patient has got total collapse, it is hypovolemia. If the size of the IVC is more than 2.5, no collapse, we are talking about volume overload. So every resident should know that. IVC tells us about volume. Simple, right? It just takes 2.5 minutes. So the point is B lines again. Every resident should learn how to look for B lines, more than 3 B lines. You are sure that there is alveolar edema. Might be cardiac edema, might be an ARDS, but yes, there is fluid in the alveoli. It's not something else that is giving rise to the dyspnea in this patient. Now, of course, imaging can be confusing. This gentleman very clearly says, this is 1, 2, 3, 4, right? And the gentleman opposing says, no, I can clearly see 3. So imaging can be confusing. And that's why when we started, we said this very thing, that look at clinical for heart failure, look at imaging, and look at biomarker. Try to combine all this so that your diagnostic capability, your sensitivity and specificity goes up. So combine as far as possible clinical features, what we have learnt, the imaging and biomarker, to make sure that your diagnosis of heart failure in this acutely dyspneic patient is right and proper. Now, what do we do? General plan of management. Look at the lungs first, right? Fix the lungs first. Fine-tune blood pressure. Think whether there is need for antros for a poor left ventricular function. Cardiogenic shock, I repeat, should go for a primary PCI, right? And arrhythmias, dyspneic patient arrhythmia, obviously you're going to give a DC shock. Worsening, ventilate. It's a very easy general plan, right? Fix lungs first, fine-tune blood pressure, inotropes, cardiogenic shock goes for PCI, arrhythmias, DC shock, and worsening goes for ventilation. Now, for the residents, BiPAP, yes, even if you can't make out what it is, cardiac or respiratory goes for a BiPAP. In cardiac dyspnea, we want to give a higher mean pressure, so high EPAP, which means when you are looking at a respiratory patient, right, and as the patient doesn't really get relief, you are increasing the IPAP from 10 to 15 to 18, right? Yes. And at the same time, you are increasing the EPAP. The EPAP remains same, so 5, 5, 5. So what are you trying to attain in a respiratory condition is a higher driving pressure. In contrast, for cardiac, what we are trying to see is that not just that as the patient is not improving, we are going from 10 to 15 to 18, we are increasing EPAP from 5 to 10 to 14, trying to give a higher mean pressure, trying to drive the alveolar fluid back into the vascular spaces. Right. Now, this is a new concept. This is a new concept, time to furosemide. We have all heard about time to angioplasty, time to balloon, time to door to needle, right? This is time to furosemide. So what they've shown is that very beautiful. This study has shown, this fairly large trial from US, has shown that if a person of cardiac failure needs a furosemide in the ER, and if you've delayed it, obviously outcomes are bad. You say, what is this? This is logical, right? A person dyspneic cardiac, I need to give furosemide, you have delayed, it would be bad outcome. But we are not talking about that. What they've shown is that even if you take the Q1, which is the lowest risk, look at that. Blue is on-time furosemide, red is furosemide delayed. High risk, low risk, both are same. So on-time furosemide, early furosemide is better. But again, we are not talking about that alone. We are talking about this. Look at that data. If you take those patients who got out of hospital, till now we were talking about in-hospital events or mortality, they got out of hospital, they went home. Even if you look at 30-day mortality of those who were discharged alive from the hospital after getting furosemide, whatever, early on time or late, you see there's a difference. So early on-time furosemide is important, even delayed 30-day mortality. So the point is, if your patient is in cardiac failure, needs furosemide, don't delay, because on time, the time between diagnosis and furosemide is important in not just short-term outcome, but long-term outcome also. Fine-tune blood pressure, because even a slightly elevated blood pressure, the ventricle doesn't tolerate. Already the ventricle is failing, right? So an afterload that is high is not tolerated, so give nitroglycerin. Try to avoid CCBs. We see that in the ER, the residents tend to give some kind of nifedipine and all that, better to avoid a CCB, right? So blood pressure, AHACC guidelines very clearly says that if your systolic BP is between 70 and 100, no sign of shock, you can give dovitamin. If your systolic BP is 70 to 100 and you have signs of shock, dopamine, and if your blood pressure is low, obviously NORAD, right? That is how it goes. Now, manage neighbors. In a cardiac failure, neighbors are very important. Anemic, CKD, CLD, medication default is taken too much of NSAIDs. Keep that in mind. Steroids, keep that in mind. That might have precipitated cardiac failure. But this is interesting and important. Bad engine cardiogenic shock. MI should be revascularized. Right. Arrhythmias, DC version. Everything fails, of course, mechanical support, IABP, Impella, VA, ECMO, depending on the level of hospital where you work. But the point is, if your patient is in cardiogenic shock and patient has MI, very often we see that people are thrombolized. Don't do that. Thrombolysis will not reach the heart, right? All you need to do is primary PCI. Understand, primary PCI has a high mortality rate, right? But the natural disease is far worse. So if you have a cardiogenic shock and acute pulmonary edema, the patient goes to the cath lab, if needed, intubate and send him, or put him on a BiPAP and send him, and he needs to get the block removed. So primary PCI is the drug of choice, is the method of choice for cardiogenic shock and acute pulmonary edema in a setting of acute MI. So suppose you say, Dr. Tiny, I am working in a small hospital, so I get a patient who is in cardiogenic shock, non-PCI center. What do I do? Do I thrombolyze? What do I do? It's an MI, right? All that you need to do is this. Today the guidelines are very clear. If you have cardiogenic shock coming to your center and you're not capable of doing an angioplasty, you don't have a cath lab, patient needs to be transferred quickly, as quickly as possible, to a center where PCI can be done. If there's a delay, you might be in legal trouble. So if you have a patient who is in cardiogenic shock with an MI, primary acute MI, he needs to go for a primary PCI, closest center available, shift him. So this is the last concept. Yeah, we are over. Just one slide, 2 slides. Let's say this is something that the residents should understand. Let's say you have a patient who has come in with an NT-proBNP of 7,000, right? And the patient on discharge, 3,000. This difference we call as wet BNP reduction. The patient comes back on follow-up after 4 months and you have an BNP, that 3,000 to 2,500 is called a dry BNP, right? So when you look at a BNP report, that 7,000 tells you that, like we said, more than 5,000, outcome is bad. He is not just in cardiac failure, his outcome is bad. But this wet BNP reduction of 4,000 tells you that short-term outcome is better. Because the quantum of reduction of BNP, post-admission, post-diuretics, tells you the short-term outcome. And long-term outcome, dry BNP. So the concept is emerging that BNP is not just one single value. You look at the initial value, the wet BNP, and the dry BNP. And the last final concept, people would ask that, Doctor, how are things, how am I doing? And I don't have BNP, I am working in a small hospital. What do I see in an acutely dyspneic patient cardiac failure? If the patient's creatinine is less than 2, and the blood pressure is less than 100, okay, you can see if the blood pressure 100 and less, creatinine more than 2 has a bad outcome, red on the right. While if creatinine is normal, kidney function is normal and blood pressure is normal, your outcome is good. So yes, this is from where we started. So acute dyspneic patient, COPD exacerbation, we were thinking that if it's not cardiac, shall we give it to Dr. Raja? The answer is probably no.
To diagnose and manage, and he has stressed upon the clinical evaluation. That is very important, which we all miss nowadays. So youngsters should take a lesson from this talk. I now request Dr. Rajadhar, who is a close friend of mine, for his pulmonary perspective.
Can I have a laser pointer, please? The rest of the team, Murli, Dr. Mani yesterday, who took me for a lovely dinner. I had a very nice time, and thank you very much for inviting me. So what I'm going to do with Dr. Nair having laid the baseline is to talk about a case where a postgraduate trainee explores various endpoints in trying to come to a diagnosis in someone who comes in dyspneic to the emergency department. So this is a real life case. This was one of my postgraduate trainees. It's called Sumit Sood. He was a second year trainee when he came across this patient on a night shift in our hospital. So this is a 64-year-old gentleman who comes from the coal belt of Bengal, from Asansol, who has a 2-day history of dry cough, breathlessness, and a left-sided chest pain. He's got multiple comorbidities, which brings Dr. Nair into the picture also. So the diabetes, the hypertension, and he's got a known history of COPD for the last 5 years, which means he's got a baseline exercise tolerance of 500 meters, for which he's on inhaled corticosteroid and a LABA, which he manages to take on a regular basis. He's got an impressive pack year history. He's been an enthusiastic smoker, even though he's stopped in the last 5 years. He's not been drinking for the last 7 years either. He lives with a partner, he says, and he's returned from Spain 7 days ago. And all these bits of information I'll come back to in a moment, so try and hold on to these bits of information. When we examined him, when Sumit examined him in the emergency department, they found that he was afebrile, he was overweight with a BMI of 32, he had a respiratory rate of 28 per minute. His cardiac signs to Sumit seemed normal. However, he did have patent swelling in the ankles, which went up to mid-shin. And when he examined him, he found crackles, which were there in both bases, but the crackles on the left side were far more pronounced as compared to the right, and he had bilateral expiratory wheeze. He had a normal heart rate, a blood pressure which was somewhat high, and again you heard Dr. Nair talking about the hypertension, which maybe leads us in the right direction in these cases. So a BP of 152/89 and saturations of 86% on room air. So that's him, and that's his chest x-ray, and you can see the left lower lobe. I'm sorry, the pointer doesn't work, but you've got these infiltrates in the left lower lobe, which looks like an evolving consolidation out there. He has an ABG which shows a pH of 7.38, a PCO2 of 47, and the hypoxia is proven with the PO2, which is 58, the bicarb being normal. This is an ABG that has been taken on room air. So Sumit steps back and thinks, what am I dealing with? Is this more the cardiology line? He doesn't have access to a cardiologist. He's the on-call at night. So he thinks, is this congestive cardiac failure? Am I dealing with someone who's got pulmonary embolism in the background of having COPD? Or the more likely diagnosis, you saw the consolidation on chest x-ray. Am I dealing with community-acquired pneumonia? Is this an acute exacerbation of COPD? So those are the differential diagnoses that he thinks about at this time. How does he base his diagnosis on? We showed you a little bit of history. He feels this is acute illness. His illness has come on in the space of 2 days. So all of these differentials would come within the ambit of an acute illness, but with the pulmonary embolus and becoming very breathless, it might be even quicker than the 48 hours that we've spoken about. Recent travel, so this could be an infection. So he could have caught up with an infection in Spain, for instance, with one of the atypical bugs. It could be that he's had a long flight, so that could be a driver for pulmonary embolism. The diabetes, the hypertension, all of these are comorbids in someone with COPD. So it could be that these factors have driven a diastolic heart failure in this individual. You saw that the blood pressure was high on presentation. The fact he has no fever confuses him a little, because with the consolidation, if this is a pneumonia, you would think that the patient would be febrile even if it's transient. He's got crackles in the bases of the lung, more on the left than on the right, we said, but crackles bilaterally. He's got ankle swelling halfway up the shin, and we said that he's got lung shadowing. So he puts these different symptoms around the differential diagnosis in coming to what he feels is the provisional diagnosis in this case. Algorithms, scoring systems. This is the acute heart failure diagnosis scoring system, which puts on various symptoms and one blood parameter about which Dr. Nair spoke about in great detail. So you can see we've got various points. There's a scoring system. So the orthopnea or absence of fever, the current loop diuretics, the age of the patient, the crackles on the chest, absence of cough, all of these together with the NT-pro and BNP gives you a score. And the score gives you a positive and a negative predictive value. So a score of 3 in this case is what he came up with. He has no fever and he has RALs on lung examination. I want you to see that graph on the end and the arrow there. So a score of 3 puts him at a very low risk of having congestive cardiac failure. If you have a score of 9, so look at the bars on the right, if you have a score of 9 and above that, the chances of congestive cardiac failure, the positive predictive value for congestive cardiac failure becomes far higher in this particular patient. So Sumit thinks the chances here of congestive cardiac failure are lower. This is the Canadian Cardiac Society guidance of 2020, which say for youngsters, when you're in the emergency department looking at patients, you don't have a lot of supervision at the time, using some of these scores might actually be useful. So Sumit thinks, okay, I've looked at the patient, I've done an NT-proBNP in this individual and that came back as being low. What about FPE? What is the evidence that we have for pulmonary embolism here? So when you think about pulmonary embolism and you assess probability, you do that under two broad headings. You feel, does this patient have clinical features compatible with pulmonary embolus? That's the first question. And you think of 4 different symptoms on there. You think of breathlessness, so symptoms and signs, breathlessness, tachypnea, chest pain, hemoptysis. This patient, you would remember, is breathless, is tachypnic, has chest pain. So he qualifies on this account, but then you have to have 2 other clinical features, and the first of them, absence of another clinical explanation, is what is spoken about. And this person has more than one clinical explanation. We know that this patient has severe COPD in the background. This patient has probably got a left lower lobe consolidation. So as far as absence of another clinical explanation is concerned, this patient qualifies for other clinical explanations, and the presence of a major risk factor. He did have a trip to Spain a few days ago, but that was as far as 7 days ago in this particular case. So if you have A plus B at the bottom, you have a high chance. If you have A or B at the bottom, then you have an intermediate chance. If you have neither A nor B, then you have an intermediate chance. So you would agree that this patient has definitely not got A. He might have B even though it dates back to 7 days. So let's say that this guy has an intermediate risk. This is the Wells prediction criteria, and on the right is the Geneva criteria, which lists the risk factors to ruling in and ruling out PE. And I won't read through this is easily available, but you understand this has got to do with risk of previous PE, factors which result in immobilization, presence or absence of hemoptysis, the heart rate, the respiratory rate, all of these put together make up the Wells and the Geneva score. And again, like the acute heart failure score I showed you, above a certain score increases your risk of having pulmonary embolism. So when you have a low or an intermediate risk, you go on to try and find out a D-dimer in these individuals. And there's various techniques of doing D-dimer. The Vidas technique, the Trinacon technique are various techniques of assessment for D-dimer. And if you have a negative score, so if you have a negative D-dimer, you have a very high sensitivity for exclusion of pulmonary embolus. A positive does not have high specificity. A negative rules out pulmonary embolism with a confidence rate of about 99.5%. So that's the confidence interval for a negative D-dimer. So in this individual, and again the D-dimer here was negative, so Sumit moves forward and thinks about investigations to do. And once he's done this thinking, those are the 5 investigations he considers: a CT pulmonary angiogram, an echocardiogram, a serum NT-proBNP, a peripheral blood cell count, white cell count, and a CRP are the various investigations he thinks of. And he thinks now that he's got rid of heart failure and pulmonary embolism as being the likely causes, he comes to CRP. He thinks that the CRP and the white cell count would be the most important investigations here. He does a white cell count which comes back as normal, but the CRP, where a cutoff is less than 5, comes back as being 150 milligram per liter. So 150 milligram per liter, so a very raised CRP, and this shows, this is the lovely paper, it's dated by about more than 25 years, but this shows you the rate of rise of CRP in patients with an acute exacerbation of COPD without infection, with an acute exacerbation of COPD with a pneumonia, or just a pneumonia by itself. And the study showed very neatly in a very large cohort of patients that if you have a CRP of less than 30, where the predicted CRP is less than 5, the chances are you have an acute exacerbation of COPD. If you have a CRP which is above 50, going much higher, the chances that the patient has a pneumonia is far greater. The prognosis of the pneumonia is poor if your first CRP is above 100. And these are all numbers which are worth remembering. So you can see the discriminative value of the two tests, one for acute exacerbation of COPD, which is mainly non-infective, versus a very raised CRP in someone who has a pneumonia. So these are certain. You remember this guy is a diabetic and a hypertensive. So question for you guys, don't know whether I have time to go through all of this or not. So with respect to diabetes and CAP, which of the following is not true? So which is the untrue answer? And I want quick show of hands so that I can finish this talk. We'll start from the beginning. So these are patients with diabetes plus CAP. Which one is not true? The incidence of CAP is increased. Is that true or untrue? So is it true? Show of hands. Show of hands if people think it's true. Okay, so a lot of the hall, 50% of the hall thinks that is true. Severity of community-acquired pneumonia, the first is incidence. The second is severity of community-acquired pneumonia is increased. True or untrue? Lots of hands again, very good. So people think that's true. The mortality of CAP is increased when you have diabetes and CAP. Hands again. So fewer hands, lesser hands, hesitant hands, but still quite a few hands who say that mortality of CAP is increased. Number 4, pleural effusion is more common when diabetes is present. Pleural effusion is more common when diabetes is present. You see one hand at the back there, no other hands, so people think that's untrue. 5th choice, microbiological causes are different when diabetes is present. Microbiological causes are present, so a lot of people think that's true. So let's look at the answers quickly and then we'll move forward. So that's the right answer. Microbiological results obtained from patients with diabetes compared to a non-diabetic population does not, I underline, does not show a significant difference. However, interestingly, pleural effusion seems to be more common if you have a pneumonia in the background of having diabetes, and that's the study from about 20 years ago which showed this. Mortality is higher, like all of you said. Severity is higher with the odds-on ratio for hospitalization of 2.2, and incidence is increased. As per 3 different studies, you have an increase of incidence of pneumonia in patients with diabetes. When you're stratifying these patients with pneumonia, that's the scoring that all of you know. That's the curved 65 score. It gives you the risk, the prognosis in patients with pneumonia. It stratifies whereabouts in the hospital you need to admit them, or even before that, whether you need to admit them at all in the first place or not. So back to my patient again, the temperature, the patient now decides to spike a temperature on day 3 of his illness and day 1 in the hospital. So he's now got a temperature which is about 101 degree Fahrenheit, 38.2 degrees centigrade, a troponin which is negative, and we spoke about the C-reactive protein. How soon after admission do you think this patient's antibiotic should be started? You heard about the door to needle time for furosemide. This is the door to needle time for an antibiotic in patients with community-acquired pneumonia. So how many people think that it's good to start within 24 hours? I'm starting from the bottom here, 24 hours. So I saw your hand, Murli, you've put it down again, within 24 hours. Go to the top. How many people think it should be within an hour? Lots of hands. So that's absolutely correct. The sooner you start antibiotics, the better it is for you. And those are the guidance, says in the emergency department, as soon as possible, as soon as possible. ADSA says 4 hours. The carry home message is the door to needle time should be as soon as possible when patients come into the emergency department. What's the best antibiotic regime? All of you know this. For someone coming from the community, you want to cover strep pneumonia the most. Hence, for a severe pneumonia admitted to hospital, you would start with a beta-lactam antibiotic with a macrolide in these individuals. This is the lovely meta-analysis, which again is very dated. Most of the literature here is actually dated, but it shows important points. What is beneficial? So systemic corticosteroids given within 2 weeks in patients who are not receiving long-term therapy with oral steroids seems to be beneficial. NIV is beneficial.
Palpitation, sweating, chest pain which radiates points towards a cardiac dyspnea. On the other hand, cough with expectoration is a parenchymal lesion, hemoptysis, wheezing, points towards a respiratory disease. Reduced urine output can be used as a differential, a symptom which differentiates. It's reduced in cardiac diseases, while in respiratory it may not be. And as Sir had said already, past history helps. Now coming to the clinical signs. Clubbing is seen both in respiratory and cardiac, but drumstick clubbing is classical of congenital cyanotic heart disease. Elevated JVP indicates cardiac cause. Pedal edema indicates congestive cardiac failure. And coming to the system examination, so I was saying S3, the gallops, S3, S4 gallop, murmurs, arrhythmias, points towards a cardiac illness, and wheezing and crepitations. Crepitations in the form of Velcro crepitation, coarse leathery crepitation points towards a respiratory. So basically with the symptomatology and clinical examination, majority of the cases we can differentiate between a cardiac cause and a respiratory cause of dyspnea. Thank you.
So Dr. Shahjahan, do you have any general strategy or principle which you follow in your hospital when managing a patient with dyspnea in the ED?
Thank you, Team Pulmocon, for this opportunity. Definitely, we have a protocol. Whenever a patient comes to ED, our major, though we have talked about many causes, our major concern, whether it is cardiac or respiratory. So, to differentiate, initially we can do, as Dr. Raini Nair has said clearly, B-type natriuretic peptide, or more specifically, N-terminal B-type natriuretic peptide. The level, if you do, you can almost all, to great extent, we can differentiate between cardiac and respiratory causes of dyspnea. And a negative D-dimer test in the setting in which you suspect pulmonary embolism, a negative D-dimer test will actually rule out the possibility of pulmonary embolism. And also, you can have a ECG coupled with the cardiac troponins. Will help you to decide upon whether you are dealing with a cardiac cause or respiratory cause. Of course, we have bedside ultrasound is with us, bedside X-ray is with us. With this extent, we are following that. But the problem is that we have to decide upon whether it is cardiac or respiratory with immediate habit. Most of the time it may be easy, but at times we find it very difficult, and we have to follow this protocol. And I think most of the cases we can differentiate with these two strategies.
Dr. Sunny, is there any newer or emerging trend in ED with which we can diagnose most of the cardiac and pulmonary causes of dyspnea?
Sir, as of now, I don't think there is something very new or interesting to be incorporated into the ED, because almost all the current guidelines what we follow is based on POCUS and the bedside echo, which can rule out the cardiac and pulmonary problems. But then AI, artificial intelligence and chatbot is the talk of the town now, and now probably it is helpful in training the paramedics. The scenarios which sir has shown, the clinical scenarios can be made easy for the training juniors, so that they can have a hand-on experience on such cases. And probably helmet CPAP, which we don't usually use instead of NIV, may be coming into the ED soon. Likewise, the improvisation of the panel of dyspnea panel, including the high sensitive troponin T, trop T and D-dimer, everything together in one single card will be available to us. Likewise, probably in many of the patients who have ultrafiltration, which is an area where we are at loss, maybe an ECCO2 removal in the ED, like an apneic ventilation strategy, also might come into the ED sooner, sir.
My next question is to Dr. Tiny Nair and Raja. How do you feel the use of POCUS in the ED? Because nowadays they are depending more on POCUS to differentiate between cardiac and pulmonary.
It is excellent because we have an imaging access to the heart, and we can clearly say is this cardiac or non-cardiac. But a real problem has come in with the introduction of HFpEF. Right. See, a lot of patients come recurrently to ED with little dyspnea worsening. We treat them with some combination of antibiotics, with some macrolides, and finally they have some fluid, they go home, come next day, we give them some diuretic, little better, and all that kind of stuff. But many of them have a HFpEF. Now this HFpEF typical character would be it's a lady, elderly, obese, hypertensive. So if you look at their ECG, there will be a little bit of left ventricular hypertrophy. Look at echo, their LV will show LVH. But the clue is the left atrium will be large. So the filling of the left ventricle is impaired. So even if you don't know how to do a Doppler, forget about it. A thickened left ventricle, large left atrium is very likely to be HFpEF. How do we diagnose? Send for an NT-proBNP. NT-proBNP will be above 300, but below that range of 1000, not to the range of HFrEF. And the point is, today we have drugs. For example, if you have a proven HFpEF, SGLT inhibitors do extremely good. Their edema subsides. They come back much less often to the hospital ED. So I think focus is good, but the point is, even at the bedside echo, unless we think in the line of HFpEF, we call them invisible heart failure. We might miss them out.
Yeah, so I think focus is very useful. I'll say something which will make me sound very ancient, but you know, the problem is with newer things coming in, Dr. Ravindran, we are losing skills which were there previously with us. So you see people in the emergency department having an ultrasound machine, but not having a stethoscope. You don't see doctors touching the patient, examining the patient, put their hand on their tummy, looking for JVP, looking for ankle swelling. They go there straight with the ultrasound machine. Equally, you spoke about very nicely about artificial intelligence. So all of these things, I think, should be add-on with what we have, not as a substitute with what we have. But then very briefly answering your question, I think it's a great armament thing to add to our armamentarian pulmonology. You look at lung sliding, you look for a pleural effusion, you look for the status of the inferior vena cava. There's multiple things that you can see. Even heart failure, you would see the septal thickening on the lungs when you see with an ultrasound. And all of these factors will help in patients who have access to POCUS in the emergency department. And I think going forward will be something which is compulsory in all EDs.
Dr. Bindu, how will you coordinate multiple departments in the ED?
Both Rajadhar and Dr. Nair was saying we'll work together. So in addition to cardio and pulmo, there are multiple causes of dyspnea like myopathies and neuropathies can cause Guillain-Barré syndrome, can cause breathlessness. So neurologists need to be involved. Cases of obstructive sleep apnea, you need to a neurologist in the evaluation. Upper respiratory tract lesions, and for the surgical management of OSA of upper respiratory, we need an ENT surgeon. Stridor, we need a tracheostomy, there an ENT surgeon is involved. Similarly, retrosternal thyroid, again an ENT surgeon is involved. Radiologists do play a role in cases of pulmonary embolism where we suspect whether it's a deep vein thrombosis, we need an emergency USG Doppler of the leg and pulmonary angiogram CT. So it depends upon the scenario where the presentation is. For example, in pregnancy, you can suspect amniotic fluid embolism, cardiomyopathies. There again, we need a team to work together. Endocrinologists where there are to rule out thyroid disorders, diabetic ketoacidosis, as we were saying, Kussmaul's respiration is seen. A physician or a hematologist in non-respiratory causes of breathlessness like anemia and blood dyscrasias, nutritionist, a physical medicine specialist where they are a part of the team of physical rehabilitation, pulmonary rehabilitation. And we all know that acute dyspnea is a life-threatening condition where in the ER an intensivist plays an important role as well as interventional pulmonologist. So this is a case of teamwork where we need to work together for the betterment of the patient.
Thank you, Dr. Bindu. Last questions to Dr. Shahjahan, which is his favorite area. How do you see patient education playing a role in recognizing early signs of the conditions that could potentially lead to acute dyspnea?
Thank you, sir. The patient education and caregiver education is the often neglected lot, but that is the most important part actually. Once the patient is known that I have this disease, this is the condition, that is the natural history, he can tolerate or he can adjust with the disease to some extent. For example, suppose you say this, when you deal with the COPD and asthma, you have to deal differently. COPD patient have some basic problem, basic dyspnea almost always. So easy fatigability, other things, you have to be careful. This when you wanted to go, when you are supposed to take your hospital or that, this we have to discuss. Similarly, in asthma, are very easy, but we often neglected. If you use a peak respiratory flow meter, you can very well predict at what time I wanted to see my doctor, or at what time I wanted to escalate my medication, all this. So this is a very neglected area, but each and every patient has the right to know his condition, and we have to educate him accordingly. Thank you, sir.
Thank you, Dr. Shahjahan. I would like to thank all the panelists. Any additional input from Dr. Tiny Nair or Dr. Raja?
Among ARDS patients. If you go through this individual trial, we can see that ARDS, the definition of the ARDS vary from trial to trial, and the different targets were utilized, including the tidal volume and airway pressure, and the tidal volume was calculated differently. That means certain trials has utilized the predicted body weight, and certain other trials has utilized the actual body weight, and certain other trials have utilized ideal body weight. So what we can see is that in all these trials, there's a lot of heterogeneity. So in this meta-analysis by the European Society of Intensive Care Medicine, they concluded that there is no evidence of difference in mortality with a relative risk of 0.6 with a 95% confidence interval of 0.7 to 1.28. But you remember that all these trials are heterogeneous. We cannot compare because the definition of the ARDS varies from trial to trial. The target of tidal volume as well as the airway pressure varies from trial to trial, and the calculation of the tidal volume was the calculation of tidal volume differed. Some trials used actual body weight, some used ideal body weight, some trials utilized predicted body weight. So the consensus is that for all ARDS patients, it is advisable to utilize a tidal volume which varies from 4 cc to 8 cc per kg, despite there is a lack of statistical significance in the meta-analysis based on the individual studies and animal data. So even after reducing the tidal volume, the outcome among ARDS patients still remain very low, very poor. So people started again thinking, why? What is the cause? What's the other factor which contributes to mortality? So the next concept, which is called transpulmonary pressure, has come. Transpulmonary pressure means the pressure inside the alveoli minus the pressure outside the alveoli. Otherwise, that's the pressure which is touching the alveoli. For example, if you take suppose a patient is ventilating with a given volume and his alveolar pressure is 30 and his pleural pressure is -5, that means the transpulmonary pressure is 30 minus -5 will be equal to 35. Okay? And similarly, if you take another patient ventilating with the same tidal volume and having the same plateau pressure or alveolar pressure 30, but that patient has got a pleural pressure of +5, that means that patient has got a transpulmonary pressure of 25. That means same patient, different patient, same tidal volume, same alveolar pressure, but the mechanical stress acting on the wall differs depending upon the pleural pressure. So based on this concept, there is another hypothesis was tested. That means the hypothesis was that keep a relatively low transpulmonary pressure at the end of inspiration so that there will be less stretch across the alveoli. And similarly, at the end of expiration, keep a transpulmonary pressure which is equal to 0 or more than 0. That means at the end of expiration, the transpulmonary pressure will be equal to the PEEP minus the pleural pressure. So if you keep a transpulmonary pressure at the end of the expiration 0 or more than 0, that indirectly means that PEEP is equal to or PEEP is higher than the pleural pressure, which will keep the alveoli open at the end of expiration. So here in this here we cannot directly measure the pleural pressure. Instead of the pleural pressure, the esophageal pressure is taken as the surrogate marker of the pleural pressure. So this hypothesis was tested in 2 trials. That's called F1 trial. F1 trial, what they did was, there were 2 groups. One is the esophageal pressure gated therapy, as we already discussed, and the second group was the conventional treatments. And the outcome was the PO to FO2 ratio or the oxygenation status for PO to FO2 ratio. What they found was, among the patients who had an esophageal pressure gated therapy, the PO to FO2 ratio was significantly higher. In the second trial, the same hypothesis was tested in the second trial, which is called F1-2 trial. Here the only difference is that the outcome they measured in terms of a composite outcome of mortality and ventilator-free days. Unfortunately, here they failed to prove the hypothesis. They couldn't demonstrate a survival benefit among the patient who tried a esophageal guided treatment protocol. So that part also has gone. And subsequently, another concept came, what is called driving pressure. The background of the driving pressure is that we know that lower the VT, lower the tidal volume, lower the plateau, and higher PEEP are protective. But we don't know how they interact each other and what is the weight of each. And from the higher level, they start reducing the PEEP. At a particular level, when alveoli start collapsing, the lung compliance start increasing. In that way, they decided the optimum PEEP. And that strategy was combined with the conventional FiO2 PEEP. They equated the esophageal pressure with pleural pressure, and then they measured the transformatory pressure. That is the pressure in the alveoli minus pressure outside the alveoli. Putting all together, this is my last slide. Putting all together, how do you go? 6 cc per kg, used 4 to 6 cc per kg is the 6 cc per predicted body weight is the tidal volume, which is recommended based on the current evidence. And you can go up to 8 cc per kg, provided the plateau pressure and driving pressure remain stable. And the pre-plateau, you have to keep a reasonably safe level, and from the current evidence, you better to keep 28 to 30 centimeter water, and the most important is the driving pressure. Driving pressure is the one which decides the mortality, and from the available evidence, it says that keep the driving pressure around 15 or less than 15. PEEP, there is no definitive way by which you can optimize the PEEP. You can go for either a best compliance method or whatever you want to, or a PEEP FiO2 table. There is not much difference, but there are so many phenotypes has been identified in ARDS. One among them is hyperinflammatory and diffuse versus the focal and non-hyperinflammatory. It has been some evidence that those patients who has got a hyperinflammatory diffuse type of ARDS, patient may do better with you can go for a higher PEEP, and those patients who has a focal pathology and a non-hyperinflammatory, that phenotype, it is better to keep the PEEP very low, at a little lower. And respiratory should be made in relation with the ventilator, with the tidal volume in such a whatever what carbon dioxide you want to keep, you can keep. But remember that respiratory rate is the one factor which decides the mortality. Keep it as low as possible. And this is the whatever shown the red line, which needs further future, that is the scope of future research, because the new variable, the 4 times the driving pressure plus respiratory rate is the one factor which was found to affect which was a predictor of the outcome in ARDS patient. This variable needs future research. Otherwise, you limit the tidal volume and you limit the plateau pressure, and more important, you limit the driving pressure. That's the most important. I limit the respiratory rate so that we can reduce the athletic trauma as well as the OLI trauma. Thank you all.
ECMO. That will be my simple answer to that. Now I invite Dr. Saji S. Nair to discuss on the topic weaning COPD patient, art or science.
Respected Chairperson, panelists, my dear colleagues, friends, and my teachers. First of all, I thank the team for inviting me for this Pulmocon 2023. Thank you so much, and with not much delay, I will start my session. So today I will be talking about weaning the COPD patient. Is it an art or a science? Dr. A.A. Mahashur. I don't have any conflicts of interest in this session. So let's start. Why we need a invasive ventilation or mechanical ventilation in COPD patients? Mechanical ventilation is typically considered when other forms of non-invasive respiratory support, such as oxygen therapy or BiPAP or CPAP, which are insufficient, and when there is a critical need of ventilatory support, like COPD patients with sepsis or pneumonia or a cardiac event in that case. But the problem is the need for prolonged mechanical ventilation can be influenced by several factors, including the patient's clinical characteristics, underlying disease severity, and response to therapy. Some of the phenotypes of COPD which may need prolonged ventilation, like severe or very severe COPD, frequent exacerbators, COPD with chronic hypoxemia, chronic carbon dioxide retainers, malnutrition and muscle wasting, associated comorbidities like heart failure. Then alpha-1 antitrypsin deficiency patients who fibrillations, like those things. So these are, any of these objective criteria is met, that means this SBT has failed. So SBT has failed, what next? You have to put back the patient on ventilator and find out why the SBT, spontaneous breathing trials are failing. So we have to search for the causes. These are the causes based on which are leading to the failure of spontaneous breathing trials. One is poorly resolved underlying cause. Like suppose if it's an infective exacerbation, patient is still having features of sepsis or pneumonia or effusion. If it is an underlying cardiac failure or pulmonary edema, some of the post-op cases when the pain or some of those things are still there, then of course the SBT will fail. Increased airway resistance, the upper airway. It could be upper airway or lower airway. Upper airway, it could be glottic edema, the tracheal injury, tracheal stenosis, tracheomalacia, all these things can. But the disadvantage is that when the patient is already on tube, endotracheal tube, it's difficult to identify whether when you extubate, the patient will develop glottic edema or there may be an underlying stenosis or where there is malacia like that. So how can we identify that even before extubation? There is a simple bedside test called bedside cuff leak test. It's a simple test by which before extubation itself, we may be able to identify there may be a chance of glottic edema or stenosis. You deflate the cuff and observe the tidal, means expiratory tidal volumes. And with cuff on and with cuff off, the tidal volume, the difference in tidal volume is more than 110 ml absolute or more than 10%. It means there is some, the leak is not happening. That means the tube is very close to the trachea. So that means the trachea is either narrowed or there may be granulomas or there may be stenos or even glottic edema. So it shows that there is a chance of failure of SBT because of increased upper airway resistance. Then post-extubation, it's difficult unless there is a strong suspicion. So clinical findings like monophonic conducted venous auscultation, it can be there because of vocal cord edema or stenosis, or even direct visualization by laryngoscopy or bronchoscopy will help us. And the treatment, we have to have either steroid if there is glottic edema, or surgical. We may ask our surgical colleagues to have a look and if needed, the correction or stenting, whatever is required. Then increased airway resistance is one of the most common causes for this failure of weaning. So it could be because of bronchospasm. There is expiratory flow limitation, there is air trapping leading to intrinsic PEEP, and poor and ineffective triggering. There is ventilator insynchrony leading to increased work of breathing. All these things are, it goes on like a chain reaction. So what we can do is we can measure this airway resistance before the patient is being considered for the spontaneous breathing trials. And what we can either by simply looking at the pressure time graph scalars, by looking at the curves, or looking at the flow volume at the loops. So more than the absolute values, it will be more helpful if you look at the progression. Suppose if we have decided the patient needs to be tried for a spontaneous breathing trial, and once we start, we have reduced the pressures, we have reduced the PEEP, we have reduced the FiO2, and he is all fit, and in the morning you find that patient is fine. So by the afternoon, if you find there is some changes there is increase in the intrinsic PEEP, or when there is difference between the peak inspiratory flow, it's going up, when there is a reduction in the compliance. These all can be seen even visually in these things. So in that case, we can always consider finding out the underlying cause and then start SBT. Like atelectasis, suppose if their static compliance is low, it could be because of atelectasis, may need some recruitment maneuvers or physiotherapy. There may be underlying pulmonary edema or abdominal distension. Suppose if there is dynamic compliance which is reduced, it could be it could be because of bronchospasm. We can give bronchodilators. If there is any secretions, we can clear them. So these are some of these based on which we can find out what's happening inside the lungs based on these flow volume loops as well as graphics. Then another important cause is neuromuscular dysfunction. So it could be myasthenia, Guillain-Barré, motor neuron disease, toxins. All these can lead to neuromuscular disorders, fatigue, and some of the peripheral causes like ICU acquired weakness due to multi-organ dysfunction, severe inflammatory state, hyperglycemia, steroids, neuromuscular blocking drugs. May present as isolated neuropathy or myopathy or both. Diagnosis, it's not easy. It's by neurophysiological conduction studies or sometimes even biopsy. We may require the assistance of our neurologist. And another important cause is diaphragm weakness or ventilator-induced diaphragm dysfunction. So it is, we can, if you can subjectively measure it by looking at the negative pressure, MIP, maximal inspiratory pressure. If it is minus 30 or even less than minus 30, the value is 40, minus 40 or minus 50, that means the patient is able to create adequate inspiratory pressure. Another mode is by looking at the bedside ultrasonography. So M mode, diaphragmatic excursion less than 1 centimeter or diaphragm thickening fraction less than 30% is considered here. This is this is the excursion and this is the diaphragm thickening fraction. So by this bedside ultrasonography, we can mention that there is diaphragmatic weakness and early shifting from control mode to the assist support modes, or if facilities are available, we can have neurally adjusted ventilatory assist or proportional assist mode. These are some of the modes which helps to overcome this. Then in addition, we can consider inspiratory muscle training exercises, antioxidants, tight glycemic control, hypercarbia. Sometimes in hypercarbia also helps to increase the diaphragmatic contractility. So means permissive hypercarbia. Then calcium channel sensitizer. Levosimendan, it's one drug which is used in cardiac failure as well, which helps to improve the diaphragmatic contractility. Then another cause which can lead to failure of SBT is cardiovascular. So patients with poor cardiopulmonary reserve, sudden shift from the positive to negative pressure breathing can induce ventilator filling pressure, afterload or LV compliance, RV preload increase. All these can lead to poor condition. Then its diagnosis is by 2D echo, and the treatment includes weaning from the pulmonary edema. Treatment includes correction of pulmonary edema with diuretics or vasodilators, CPAP or non-invasive ventilation. It's very helpful in such cases. And the psychological factors, of course, we have to look for. So electrolyte and metabolic endocrine factors, all these we have to look for. Conclusion, weaning from COPD, weaning from ventilator is sometimes it's not easy. It's more than an art. Scientific approach may be appropriate. And checklist for appropriate factors, it will be ideal. Thank you for this listening.
The rules are there, but individual patient can differ. That's what I would like to add to that. Now I request Dr. Ganesh Balan to have the lecture on the topic critical care training for pulmonologists, opportunities and challenges.
So to summarize, critical care training gives you a unique opportunity to work in a fun, fast-paced, inspiring, exciting environment where everything you do definitely makes a difference to patient outcome, difference to patient's family, and difference in oneself. You'd ultimately get a sense of accomplishment. So thank you. I want to end with the poem Yan Pentra Inbam Pergai Vayagam. So I want to, my fellow pulmonologists, to get the bliss I received by undergoing critical care training. Thank you.
Thank you, Dr. Ganesh. Second question is, when will you intubate an ARDS patient who is on non-invasive support?
If you go through the evidence-based medicine, if you go through the recent ESICM guidelines and meta-analysis, they have clearly combined, they have pulled all the data and they have clearly combined the use of HFNC, done a head-to-head comparison between the HFNC and NIV. Overall, I can say that HFNC will reduce the probability of intubation compared to standard oxygen therapy. But when we compare the NIV versus HFNC, there is insufficient data either to recommend or favor any of these modalities.
So when will you intubate an ARDS patient?
That's a clinic, by clinical sense only. Rather than going for any number, I think it is better to assess the patient clinically after starting a non-invasive strategy. We can assess the status of the respiratory rate, the work of breathing, the use of X-ray muscles, the blood gas, heart rate, everything, and you can assess, and accordingly you can decide. If you want to go, if you utilize some subjective data, you can. There are many indices are there like HACOR, ROX, and so many. Saturation effect ratio, PO2 effect ratio, respiratory rate. So many indices are there, but I think it is more of a clinical decision rather than a number.
So the answer to the thing basically, whether you do an HFNC in NIV, initially there is one trial, this is called 4RA trial. There is no time to discuss in detail. This has combined, this compared in HFNC versus, NIV and ARDS. And surprisingly, in this study, the 90-day mortality was, more in patients who are on NIV, non-invasive ventilation. And this is, again supported by another study called Lung Safe trial, LUNG SAFE trial, which again they found that the patient who was on, the non-invasive ventilation, the increased mortality was observed. But having said that, the issue for this is that when you put the patient on an NIV, what is going to happen is that you have a set pressure support. So what is going to happen is when the patient is triggering, the gush of air is going to just pushed into the lung, and you won't be having a control of the tidal volume. So many patients may be having higher tidal volume. The higher tidal volume may be generated by most of the NIV thing, the non-invasive ventilation. So that could be the reason. This could because it's a volume-induced lung injury could be the reason for this kind of increase mortality. This is a scientific concern. But having said that, based on the current evidence at this point of time, there is no strong evidence of whether NIV is better or HFNC is better at this point of time. And I personally believe that patient who is having an underlying obstructive airway disease may be more comfortable with non-invasive ventilation rather than HFNC. This is one thing which is with the helmet mask. There's a new NIV thing with the helmet mask is nowadays available. It is using the pressure support will be less, the peak will be high. This has been, studies have shown that this is supposed to be much better in mild to moderate ARDS when compared to the conventional NIV. But again, we need further studies. So the second question is Dr. Ganesh Manan. How will you titrate PEEP in your ARDS patients? So we are not talking about the theoretical thing, just want what you do, just want to know.
Most of my patients, when I follow the PEEP FAO2 table of the ARSNet protocol, they improve, sir. Very less number of patients who we can't get an adequate PEEP. I go with the lower inflection point method.
So what do you do in your practice? So basically in our practice, this is an ARDS net trial. This is the PEEP protocol which they have. And this is freely downloaded, everybody is using that. Depending on the various FiO2, for example, 0.3, you can give a PEEP of 5. And you can see that when the patient is 100% oxygen, you can give a PEEP of around 18 to 24 hours with this protocol. But having said that, in my practice, basically we have never been able to use more than 15 centimeters of PEEP. Because the moment I use more than 15 centimeters of PEEP, what I face is that most of the time the blood pressure will definitely go up. And if the patient is on a pressure control mode, the tidal volume the patient getting will be very, very less. And the carbon dioxide will go up. So we have a time constraints. What I mean to say that most of the time, whatever the titration of the PEEP is done by the ARDS next protocol, which is definitely freely available anywhere in the literature. And obviously, like Dr. Ganesh has mentioned, you can go for the pressure volume curve, but it is not very practical because when you are on the ventilator, you are not giving the right curve. Second thing is that even if you go for the so-called lower inflection point, just 2 centimeters above, studies have shown that even if you do this peak titration, it is not going to make a difference to the patient's outcome. So basically these are the other academic things. And obviously now people are doing peak titration using ultrasound as well. That is just to mention in between. So Dr. Vinod Kumar, so when will you prone your ARDS patients? I am talking about the mechanically ventilated ARDS patients. And when will you consider ECMO for ARDS patients, your ARDS patients?
So proning, first we must be aware about the manpower that needs to be present. There should be trained staff, which should be around 3 to 4 staff do a proper proning. And in case the patient is on ECMO as well, the number of staff required to do a safe proning goes up to 5 staff to do the proning. And the indications to take a patient for proning is moderate to severe ARDS, which has been defined in the trial as a PF ratio, PaO to FaO2 ratio less than 150, and the PEEP pressure, the PEEP should be around 5 centimeter, and the FiO2 should be 0.6. So these are the criteria, and the patient should be hemodynamically stable for at least 12 hours before you try a proning. And once these conditions are met, the patient should be taken for proning within 36 hours. So these are the indications, and of course there should not be any contraindication. The absolute contraindication being an unstable spinal injury or cervical spine injury. And relative contraindications are facial trauma, and the pregnant patient should not be pregnant, and there should not be many burns, and the patient should be hemodynamically stable. So these are the situations where we can consider proning a patient.
So when you say when you are going to prone the patient, my answer will be that when the patient is on a ventilator, the PaO2 by FiO2 ratio is less than 150, we will prone the patient. That will be the criteria. This is a landmark trial, it's called the crossover trial. We have shown that early and prolonged weaning has better significant difference in the mortality. So what I mean is saying that you need to go for the early proning. The moment that PaO2 FiO2 ratio is less than 150, you can prone. And you have a prolonged proning. What I mean is that you need to prone the patient at least within 80 to 12 hours. So this is the thing about this trial has shown. And basically coming to the ECMO. So once you prone the patient is still hypoxemic, then you need to consider about ECMO. So there are lots of criteria out there. One of the things is about ELS of criteria, X of criteria. So in ECMO, an ARDS patient, in a hypoxic respiratory failure due to any cause, primary or secondary, extracorporeal life support should be considered when the risk of mortality is 50% or greater, and indicated when the risk of mortality is 80% or greater. What I mean to say is that you consider when the mortality is 50%, but when it is more than 80% or greater, you have to do the ECMO. So when it is more than 80% or greater, is the PaO2 FiO2 ratio less than 100, the bottom paragraph, or a FiO2 more than 90%, or a Murray score of 3 to 4, despite optimal care for 6 hours or more. So you keep the patient, you wait for 6 hours, and if this criteria is that FiO2 more than 90%, PaO2 FiO2 ratio is still less than 100, you need to definitely get the mortality is more than 80%, you need to prone the patient. So this is the Murray score, there is no need to discuss that, because we have constraints of time. And this is about, now the question is that is ECMO a useful management strategy in ARDS or only a mere hype that should be involved? And what are the practical challenges you come across on BV ECMOs in ARDS? Because so I just want to say that honestly, I would say that, see, in the last year, at least for 3 years, there has been definitely there's an increased surge of usage of ECMO. In our experience and all over the world, there is increasingly better and better research have been, it has been produced by the ECMO management for the ARDS patients. Obviously, some of the end-to-end trials, severe ARDS, if you use ECMO versus if you use mechanical ventilation, they have failed to make a difference in outcome. But in patients who have refractory hypoxemia, so these kind of patients, if you put on ECMO the right time, before the patient is going early ECMO, before the patient goes into multi-organ dysfunction, especially in a patient, especially in a center where you have a high volume of an ECMO facilities are there, the outcome is definitely going to be better. In our experience, the international guidelines says that around 50 to 60% survival is there. We also had, during our COVID time, we had put around 20 patients in ECMO, around 11 are survived, obviously we lost 9 patients. And they said that even in COVID patients, many people used to write that in COVID ECMO is not useful. Even in COVID patients, the results are as good as 50 to 60%. That is for all for the non-COVID patients. So what I mean to say that ECMO is not as high. If you go for an early strategy, it is definitely going to, early initiation of ECMO is definitely going to be helpful to the patient. practical challenges in ECMO in India, my observation is that severe infection, we have multi-resistant infection. ECMO is a long course, it may be at least from 20 to 40 days for a simple ARDS in our experience. So when you deal with the antibiotics for this long, the chance is that in India what's happening is that within a week's of time, the patient will be having multi-resistant organisms and there is no more antibiotic, the patient is going to be lost. So the antibiotic resistance and the multi-resistant resistance is very important, and the most important message from me is that we all need to practice and support antibiotic protocols and the antibiotic stewardship with this practice. So there is one more question is that because of time constraint, I'm just going to stop it. Thank you very much. Any questions from my audience? You can take.
COVID results were lower, definitely.
Yeah. So if you're having a high volume over a period of time, the learning curve is there. Over a period of time, if you keep on doing that, definitely the outcome is definitely going to be very much better. And early ECMO, before the patient going to multi-organ dysfunction is the thing, ECMO is not the last resort. That's what I want to highlight. That is not the last trigger, last resort like many people would say. It is an early resort, give initial ECMO at the right time, you are very likely to save the patient. Thank you. With this, we resolve this panel discussion. Thank you very much for your attention.
Corticosteroids in COPD. What was beyond 2016? No use of inhaled corticosteroids in COPD. And what is coming in 2023? Maybe you can use inhaled corticosteroids in COPD. So this somersault which is happening at the level of gold, only the gold knows. But for a couple of people who do not know, I would like to remind all of you, gold is downloaded in 200 countries in the world. That does not mean that all these 200 countries have taken the oath to follow this gold in their daily practice. And that's what I'm going to expose you to today, why there is a discrepancy in what gold says and the makers of this so-called as gold don't recommend in their own countries. So this will be very surprising to you. But look at this. Now upfront therapy of patients of COPD are given group B, group A, group E, and nowhere here is written inhaled corticosteroids. Correct? Agreed. Look at it that if you continue to suffer, then you decide whether you are suffering because of your breathlessness or you are suffering because of your exacerbations, and it gives you a tree down here that a dyspneic patient cannot do anything more than a dual bronchodilator. So one bronchodilator, two bronchodilator, and then continue to suffer. Okay. What about exacerbating ones? If you have given LABA, you give them LAMA. If you have given them LABA, you give them LAMA. If you have given one drug, give them two drugs. And finally, if you have a good eosinophils with you, good number, not good eosinophils, they are bad eosinophils, they need to be targeted, but number should be good. So if you have a 300, you still get promoted to triple therapy, which includes the inhaled corticosteroid. And of course, if you continue to suffer on two drugs again and again, getting exacerbations, hospitalizations again and again, the poor guy, even with 100 numbers of eosinophils, gets qualified to get an absolute triple therapy, which includes the inhaled corticosteroid. Now, you will say, what's the big thing you are telling us? We all know about it. I'm going to tell you, just wait. The most important thing is that these many things are hidden in it, and I am going to discuss that. So, initial treatment. Gold is recommending LABA, LAMA, LABA, LAMA, LABA, LAMA, right? Everywhere. Where? On the basis of what? These meta-analysis? Yes, they have spoken about this meta-analysis, where it is shown that the LAMA is better than ICS, LABA is better than ICS, LABA LAMA is better than LABA or LAMA. Yes, exactly here. Correct. What are the group of patients which were recruited in? already diagnosed COPD patients, already on treatment. So you are extrapolating the data of patients who are already diagnosed COPD, already on treatment, they get into the trials, they get withdrawn their treatment to get into that randomized arm, which is A, B, or C, and then you get this kind of a data and then you recommend it. So, do people know about it? This is meta-analysis. You can see that. What it suggests that the ICS addition to any non-ICS therapy decreases exacerbations. So why do you want patients of your exacerbation suffer when it is reducing exacerbations? Why do you want them to have 2 more or 1 more or 3 more or 4 more? Why? Okay, let's see. Yeah. First I will come to this dyspnea. Laba lama and nothing left. Now look at it, what happens next. Now, this is a triple versus laba lama combination, systematic review 2022, which shows that those patients who have got FEV1 of less than 80%, they benefit in reduction in dyspnea and improvement in quality of life by adding ICS to laba lama. It is not there in the gold. Okay? I do not know why gold ignored it, but I can understand because this is 21. But look at this. Now one big chunk of that gold, which is Canadians, went away, made their own guidelines in 2023 and say that those patients who are not improving on laba lama with dyspnea should be given inhaled corticosteroid, should be put on a triple therapy and step it up to triple therapy. Because, and they talk about it, Chronos, Ethos and Impact has shown that it improves dyspnea. Why do you want to divide them of that? I know that there will be a lot of chatter which will come about the side effects and pneumonias. I know that. I'm going to deal with that later. But the question is, those people who were the part of gold, at that point of time, they did not consider this. But when they come up with their own country guidelines, then they change. People behave differently. Can't help it, actually. Life is like that, right? Okay. Yeah. Now look at UK. The brighter, right? The white. And we are always very impressed by them. Why not? Nice. 2018. Step up laba lama to triple therapy for 3 months trial and see whether the patient is feeling better or not before saying that it is of no use. Where are these UK people in the gold? They are very much there. But for their own country, different guideline. Very good. Nice. ATS. Big chunk, Americans in this, brings out their own guidelines, 2013. Look at it, what is written. Add inhaled corticosteroid and make it a triple therapy for the patient who continue to suffer. Why is this disparity? Because this 200 countries constitutes nearly 85% of countries called as low middle income country, and India is bracket in that. And they want them to save the money, or perhaps whatever are the reasons which is best known to them, not to me at all, that they do not make similar recommendations when they sit on the gold committee, and they make different recommendations when they go back to their own countries to do it. Very difficult. Second part, exacerbations. You continue to have exacerbations to be qualified to ICS. Why? You know that a patient who develops an exacerbation in COPD, 50% of them will develop another exacerbation within 1 year. Why you want 50% to suffer before they qualify to get an inhaled corticosteroid? Because every exacerbation causes 37% faster decline in lung functions, poor quality of life for 6 months, and very importantly, carry the mortality risk, 50% risk of death at 5 years. You still want to carry on with that extra exacerbation to do what in this 180 poor countries? I do not know, gold only know that. And this is despite that we all understand, all meta-analysis shows the most potent drug to decrease exacerbations in COPD is inhaled corticosteroids. And you can see that it is 24% extra by adding to baseline LABA-LAMA combinations. Any therapy which does not contain ICS, you add ICS, you get extra 25% or 24% reduction in exacerbations. This is of no value to us. How can it be? Then why not recommend it upfront? Triple therapy for those who are exacerbating? Okay. So they talk about eosinophilia, right? And they say if your eosinophils are high, then only you consider it, and defined as 2% and more than 150. The most important thing is no randomized trial exists which had the baseline eosinophil to be considered as one of the marker to decide whether exacerbations will decrease or not decrease. It is all extrapolated data, all extrapolated data. Nobody, there was this threshold which they have defined is very difficult to support in clinical practice, and for that reason, our friends, Canadians, again went away by saying that these eosinophils, we do not go by that. We go by patient who's suffering with CAT of more than 10, MMRC of more than or 2, or FEV1 of less than 80%, and not believe in the eosinophil data here. Wow, very good. The question is, why not without ICS? And this is primarily the latest data, which you can see the meta-analysis, which clearly shows that the exacerbation potential is significantly reduced by adding the inhaled corticosteroids. So, my dear friend, Rajesh might be having gold, but I don't need this gold, okay? Let's keep it, forget it. Now come to pneumonia risk. Everybody will now come and chatter about pneumonia, pneumonia with ICS pneumonias will happen. What is this pneumonias? They happen only with the highest doses of inhaled corticosteroids. We are not saying use the highest dose of inhaled corticosteroid. It happens with fluticasone furoate. We are not asking you to use fluticasone furoate. And also, it is not happening with budesonide, beclomethasone, and some other ones which are recently available. So why put everything into one bag and treat them together? Simple. Because one is available everywhere, which is salmeterol and fluticasone, and continue discussing about that and forget it. And then give this beautiful table, which is like very well understood by us. I agree with that, strongly in favor, not in favor, all those things. The typical red light system has been shown here, and they are very happy with that, which goes on talking about eosinophil, 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 fine. Eosinophil story, I have already told you why to go on that. But remember, the goal of management of COPD is not only to improve symptoms and other things, but very important, reduce mortality of the patient. Has any intervention shown reduction in mortality in COPD till date today? Yes, only one. What is that? Smoking cessation. No drug therapy has been used to do it. And this is the same article which shows that there is a reduction in mortality. There is a mortality benefit of adding inhaled corticosteroids to a dual therapy of LABA-LAMA. And it's not that there are 1, 2, 3, 5 trials. There are enough trials on that. And they had good number of exacerbations in that to document that the effect of adding on ICS is real. So let me ask you, my dear friends, how many of you have seen Shakespeare's Merchant of Venice? How many of you, please raise your hands. How many have seen Merchant of Venice? No, there are no Shakespeare lovers here. My God, I can't even imagine my life, because half of the English which we use in all our debates, in all our lectures is primarily borrowed from Shakespeare only. I should know that, okay. So Act 2, Scene 7, where the beautiful girl, this is just the second last slide, please. Stop the sound. So, you know, that beautiful bride is waiting to be given to Prince of Monaco and Prince of Aragon, and they have been asked to choose bronze, gold, and silver. Open the casket, and in one of it, there is the princess. And whosoever opens the right box will get it. And I won't go into what is written there, but it is something which you should all read, because that gives one answer very clearly, that all that glitters is not gold. So the one who chose the bronze actually won the princess. And who was that? Merchant of Venice. Simple, right? So maybe this is something which I want. There's sound to be given. This is for you, Rajesh. What else you want? Come on, have the stage.
Thank you, Dr. Talwar. Let's give him a big applause. Sordar Talian. Louder. We are always very much, reluctant to give loud applauses. Next session is about why we should not use ICS in stable COPD. Dr. Talwar, you can come and sit in.
A very good evening to esteemed faculty, delegates, and organizers. At the outset, I would congratulate Team Pulmocon Trivandrum for coming up with this scintillating academic show, and I would like to place upon record my sincere gratitude for allowing me to be a part of this star-studded faculty, and that too with Deepak sir, whom in my right from my post-PhD. Sir has very clearly impressed upon that ICS is required in stable COPD, so let me try what I can do to counter that. Okay. So I hope I won't cut a sorry figure at the end of this particular pro-con debate for two reasons. Okay. First of all, I have to talk against a strategy that I believe, preach, and practice. So I don't know how effectively I can do that. And secondly, I have to talk against Deepak sir, who is an academician par excellence, a mentor to many of the mentors, and at a personal level, a professional idol of worship. But having accepted this particular pro-con debate, I have no option other than to go ahead with that. So, okay. So I'll start off with a disclaimer that I will move away from blind opposition towards judicious criticism, and I will try to share the lacunae in evidences and the knowledge voids that exist with regard to usage of ICS in COPD. So the definition of a stable COPD has a huge bearing on our pro-con debate, because the way in which a stable COPD is defined can switch the pendulum between Deepak sir and me for this particular pro-con debate, because as I will come to in my subsequent slides, most of the evidences of ICS in stable COPD come up with the triple therapy combination, LABA, ICS combination in COPD. And we have a lot of studies, landmark trials on triple therapy in COPD, both the BDP, formoterol, glycopyrronium, the fluticasone, lansoprazole, umeclidinium. You have the fulfill and the impact trials. And we have the formoterol, budesonide, glycopyrronium, the chronos and the ethos studies. And if you see the inclusion criteria of all these, the two landmark ones will be the ethos and the impact. If you see the inclusion criteria of most of these studies, they have looked at patients who are frequent exacerbators and who have a reasonably declined lung function, not totally declined lung function, because 50 to 80% FEV1 is there in the inclusion criteria, but most of them have looked at patients who are frequent exacerbators. So if stable COPD is defined as a COPD where the patient is exacerbation free or has very few exacerbations, say 1 a year or something like that, he has reasonably preserved lung function and no asthmatic component to his COPD, then probably I have my job pretty easy, because ICS has no major role as per all these evidences. Whereas if stable COPD is defined as someone where some frequent exacerbations, poor lung function, asthmatic component, all those things, but a static bad stable COPD, then obviously sir would have an edge on that. But the bottom line of this definition is that ICS is not a drug for each and every patient with COPD. That is the bottom line that we want to make. So if we come to the evidences of ICS monotherapy and ICS LABA in COPD, it's a big no-no, as I will come to with the subsequent evidences. There have been multiple studies of ICS as a standalone drug in COPD, and there has been a meta-analysis of almost 12,000 patients in this regard. of almost 12,000 patients in this regard. And this has shown that there is a relatively small but statistically significant reduction in the mean exacerbation rate with ICS, and there is some increase in the rate of pneumonia also. And in the TORCH trial, there was a trend towards higher mortality in those patients who were treated with fluticasone. So, ICS as a monotherapy, that is a standalone ICS in COPD, is a treatment therapy that is not recommended or encouraged. I don't think there is any controversy in that. Whereas, if we see LABA ICS versus placebo trials, we have the TORCH and SUMMIT trials. Both of them failed to achieve the primary objective of a statistically significant ICS-related reduction in mortality. Fair, but there was some reduction in exacerbations and improvement in health quality of life, but a post hoc analysis of the TORCH trial in fact showed that the survival benefit is associated with the LABA component but not the ICS component. So now comes a bit more serious discussion of ICS LABA versus LABA LAMA. So can ICS fit in that way? Again, we have the landmark FLAME trial, which had an inclusion criteria that was very similar to our severe COPD patients coming to most of our clinic. That is someone who has frequent exacerbations, who has bad lung function and all those things. And it was shown that the primary outcome, that is the exacerbation rate over 1 year, was better with the LABA-LAMA as compared with the ICS-LABA group. So again, the time to first exacerbation was prolonged by LABA-LAMA. So based on the FLAME trial, the scientific world started to acknowledge that LABA-LAMA is superior to ICS-LABA in COPD patients. So whatever I said up to now, ICS monotherapy is not preferred, ICS-LABA as compared to placebo is not preferred, ICS-LABA versus LABA-LAMA, LABA-LAMA is slightly superior. So this much is clear. I don't think there is a major controversy or debate in that. Now comes the real difficult part, that is ICS as a part of triple therapy, that is LABA, LAMA, ICS in patients with COPD. Here, there are a lot of evidences that favor ICS, but what I am trying to put across as a part of my opposition to the ICS strategy is the methodological issues in the design and analysis of these studies and some confounding effects with inclusion of patients with different histories and all those things. I will come to each one of that in the subsequent slides, and that would be probably the crux of my debate on that. Now, the two most important trials which have shown us that ICS in combination with other two things, that is triple therapy, is superior, are the IMPACT and the ETHOS. Now, both these studies did not include patients with a past history of asthma. So that is contrary to usual COPD studies where they exclude patients with a past history of asthma. Okay. Again, if you see the inclusion, if you see the patient category, a substantial chunk of these patients had frequent exacerbations with a relatively preserved lung function. So that again is not characteristic of the COPD patients that we see in our day-to-day practice, because many of those COPD patients who are frequent exacerbators have poor lung function also. A preserved lung function with frequent exacerbations is characteristically seen with poorly controlled asthma. So this ETHOS and IMPACT have selected an unusual asthma-like COPD population compared with the general COPD population. So the results of these studies may not be extrapolatable to the general COPD population. That is one of my arguments. And the second one, if we see the run-in period of the ETHOS and the CHRONOS study, what they did was prior to randomization, there was a 1 to 4 week period where they stopped all inhalers, all inhaled bronchodilators. So LABA was stopped, LAMA was stopped, LABA-LAMA was discontinued. They just gave inhaled ipratropium to this category of patients. And those patients who were on ICS-LABA, they withdrew the LABA and allowed ICS to be continued. So what did it result? This resulted in a very large pre-randomization dropout rate due to exacerbations. So almost 38% in the CHRONOS and the 46% in the ETHOS. So we were left with a relatively ICS sensitive population that actually went to randomization. So that might have influenced the results of the the benefits of ICS in these particular studies. So again, the selection of ICS sensitive COPD patients is different from a general COPD population. Third one, again, those patients we have already selected a relatively ICS sensitive population. Once they were randomized to two arms, LABA-LAMA versus triple therapy. Okay, so 70% of these patients on these trials were already on ICS and 40% were already on triple therapy. So it's like sudden stoppage of ICS in a population that is sensitive to ICS therapy, who are beneficial to ICS therapy. So this probably contributed to increased exacerbation and mortality in this impact, ethos, chronos, all those studies. And that is evident from this particular clustering of exacerbations and mortality. If you see the impact, in the first month, there was almost 15 exacerbations per 100 patients in the dual therapy arm, versus only half, around 8.7 per 100 persons in the triple therapy arm. But after the 1 month, the exacerbation rate was 4 per 100 persons in both, whether it was dual therapy or triple therapy. So the initial abrupt withdrawal of steroids would have contributed to this frequent exacerbation in the initial part. That was the impact, and similar results were seen in ethos also. The initial 1 month, there was a lot of exacerbations, but after that, the similar exacerbation rate in both the triple therapy arm versus the dual therapy arm put together. So, if I can summarize the methodological flaws of the triple therapy studies, they included past asthmatics and asthma-like COPD population. They withdrew all bronchodilators in the run-in period, creating frequent exacerbations and dropout rates. They abruptly stopped ICS after the randomization in an ICS using or ICS sensitive cohort. And there was a false interpretation of early clustered mortality and exacerbation rate as due to sustained improvement in mortality and exacerbations due to ICS use. Now this much, and again, if someone doesn't believe this argument from me that there were methodological flaws that actually contributed to the apparent benefit of ICS in these triple therapy arms, okay, go ahead and use ICS in this category of patients, absolutely no issues on that. But just because of the fact that you have started ICS in this particular group of population doesn't mean that you should eternally continue them on ICS. Because the dynamics of COPD control in an individual patient with COPD changes with time. Some of the frequent exacerbators who are initiated on ICS start experiencing better control with fewer exacerbations and better symptom control. So ICS de-escalation is feasible in this proportion of this category of COPD patients, which is actually demonstrated in the Wisdom and the Sunset trials. The Wisdom trial actually looked at patients with very bad lung function, but hardly any exacerbations in the last 1 year prior to therapy, 0 or 1 exacerbations, and they switched them to continued 1 arm on triple therapy, 1 arm on LABA/LAMAs, and it was seen that the time to first exacerbation was similar in this group, which was actually de-escalated to a dual therapy. And most of the outcomes were within the non-inferiority margin in the Wisdom trial. Again, the Sunset was similar design, but slightly less sick group of COPD patients who are FEV1 was 40 to 80%. Same study design, and it was seen that although the trough FEV1 was slightly less with LABA/LAMA as compared to the triple therapy, the exacerbation rate was similar in both groups. The moral of the story is that those COPD patients who are on triple therapy who improve with less of exacerbations, you can try and de-escalate them to a dual therapy. I think Deepak Sarwar sir is going to finger me on this, but there is a small but substantial risk, small but definite risk of pneumonia in those patients who are treated with ICS. The risk is very clear with fluticasone than budesonide, and the regulatory authorities have advised to exhibit this as a warning. So it is not great, but it does exist. So if you see the Cochrane database analysis, fluticasone increases the pneumonia risk. Over 18 months of therapy, 18 patients per 1,000 patients treated with fluticasone get an episode of pneumonia, whereas with budesonide it is much less. Over 9 months, 6 per 1,000 patients treated with budesonide get a pneumonia. A lower daily dose of budesonide is associated with much less risk of pneumonia than a slightly higher dose, and this doesn't translate to increased mortality. It is there that there is pneumonia, but it doesn't lead to a high degree of hospitalization or mortality. Finally, in the ethos and the chrono study, we have the formoterol budesonide glycopyridine that is used, and these particular studies used a particular delivery device, that is aerosphere, delivered by, prepared by the so-called co-suspension technology. So this is probably going to come to India in the next year, but as of now, these formulations, the triple therapy with formoterol, budesonide and glycopyridine in India are being marketed as the pressurized MDI. So would the results be replicated with the same devices as with the co-suspension technology is a matter of debate. Are the advantages obtained in these triple therapy trials due to the drug per se or the delivery device per se? We don't know. So challenges with the traditional pressurized MDI is that there can be drug-to-drug interactions when all of them are combined. The suspension may not be may be non-uniform. The chemical and physical stability may not be there. There can be inconsistent drug delivery both at the delivered dose and aerosolization levels. So this is my last slide. So the take-home messages from the first part of our discussion is that ICS monotherapy has no role in COPD. ICS LABA therapy is also not recommended in the absence of a LAMA. Triple therapy has the maximum evidence, but I was trying to tell that there are methodological flaws and skewed design in many of these triple therapy trials, which limits the generalization of these trial results to the general population. And even if you are using ICS discontinuation is feasible and recommended in the so-called very stable COPD patients without much exacerbations. And there is a discordance with the drug delivery system that is used in trials versus the ones that are available in India, and that too with a much higher cost. Thank you.
Excellent, Dr. Rajesh. Give him a big hand. Big applause. Dr. Rajesh, we understand your difficulty.
The point outside the hall to receive the memento. GB meeting will start soon in this hall.
And that was this, that I think I have done more than 30-40 debates so far in my life, almost every year, 2, 3, 4, 5. I have never ever seen a referee like him here. He has not only propelled this debate so wonderfully, concluded it exquisitively, extensively, beautifully, and crystal clear. Thank you very much.
Thank you. Thank you. I am honored and flattered. Thank you.
അടുത്ത ആൾ അതുപോലത്തെ ഒരു സിമിലർ സ്റ്റഡി പബ്ലിഷ് ചെയ്യുമ്പം അതിനെങ്കിലും ഒന്ന് സൈറ്റ് ചെയ്യണം. പൾമോൺ പോലും വായിക്കാത്ത ഒരാൾ പൾമോണിൽ പബ്ലിഷ് ചെയ്യാൻ ശ്രമിക്കുക എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അത് ഈവൻ അലോ ചെയ്യാൻ പാടില്ല. നമ്മളപ്പോൾ ഈ പറഞ്ഞ ഇപ്പം നമ്മൾ APSR ജേണലിലൊക്കെ പോയി കഴിഞ്ഞാൽ അവരുടെ ഒരു പ്രീ കണ്ടീഷൻ ഇസ് ദാറ്റ് നമ്മളെ ജേണലിലുള്ള ഇത്രയും ആർട്ടിക്കിൾ നിങ്ങൾ റെഫറൻസ് ആയിട്ട് വെച്ചിരിക്കണം, എന്നാലേ ഞങ്ങൾ പബ്ലിഷ് ചെയ്യാൻ സമ്മതിക്കുള്ളൂ. ഞാൻ പേര് പറയണില്ല, നാഷണൽ ലെവലിൽ നമ്മളൊരു ജേണലിൻ്റെ എഡിറ്ററുണ്ട്. അദ്ദേഹം ഒരു ആർട്ടിക്കിൾ ആ ജേണലിൽ നമ്മൾ പബ്ലിഷ് ചെയ്യണമെങ്കിൽ അദ്ദേഹത്തിൻ്റെ പേരിലുള്ള ജേണലിലുള്ള ആർട്ടിക്കിൾ നമ്മൾ സൈറ്റ് ചെയ്യണം. എന്ന് വെച്ചാൽ അദ്ദേഹത്തിൻ്റെ സൈറ്റേഷൻ സ്കോർ കൂടും. അപ്പോൾ അങ്ങനെയുള്ള പല പല പരിപാടികൾ ചെയ്ത് നമ്മളുടെ ആർട്ടിക്കിൾസിൻ്റെ സൈറ്റേഷൻ കൂട്ടിയില്ലെങ്കിൽ ജസ്റ്റ് കുറേ ആർട്ടിക്കിൾസ് വന്നു ഒരു ജേണൽ ഇറക്കി എന്ന് പറഞ്ഞാൽ ഒരു അർത്ഥമില്ല. ഇന്നത്തെ കാലത്ത് എല്ലാവരും ഇൻഡിവിജ്വൽസ് ആയാലും നമ്മളെല്ലാവരും നമ്മളുടെ സ്വന്തം സൈറ്റേഷൻ H ഇൻഡെക്സ് നോക്കുന്നുണ്ട്. ജേണൽസിന് അതുപോലെയുള്ള സ്കോറിംഗ് സിസ്റ്റം ഉണ്ട്. അത് കൊണ്ടുവരാതെ നമ്മൾ വെറുതെ ജേണലിൽ ഇങ്ങനെ കുറേ ആർട്ടിക്കിൾ പബ്ലിഷ് ചെയ്ത് ഇങ്ങനെ കൊണ്ടുപോയിട്ട് കാര്യമില്ല. നമുക്ക് മെത്തഡോളജി നമ്മൾ തന്നെ പ്രൂവ് ചെയ്തിട്ടുണ്ട്. പൾമോണിൽ നമ്മൾ തന്നെ ആർട്ടിക്കിൾസ് ഉണ്ടാക്കിയിട്ടുണ്ട്. ഇനി അങ്ങനെ ചെയ്യാൻ പറ്റും. ഐ തിങ്ക് യു ഷുഡ് ടേക്ക് ഇറ്റ് അപ്പ് വിത്ത് the incoming president, and that has to be done immediately.
Time moves. I think more and more citations should come. So we'll try for that.
ടൈ അപ്പ് ചെയ്യുന്നതിന് മുമ്പ് ഫ്രീ ആയിട്ട് ചെയ്തു. ചെറിയൊരു എമൗണ്ടിന് 2 എഞ്ചിനീയർ പിള്ളേരെ കൊണ്ട് ചെയ്യിച്ചു. അവർ ചെയ്തു തന്നു. പക്ഷേ അതിനെ എനിക്ക് ഒറ്റയ്ക്ക് അതിനെ കൊണ്ട് റൺ ചെയ്യാൻ പറ്റുന്നില്ല. കാരണം എനിക്ക് അത്ര നോളജ് ഇല്ല അത് അപ്ഡേറ്റ് ചെയ്യാൻ. ഒന്ന് എൻ്റെ മകനും അവൻ്റെ ഫ്രണ്ടുമായിരുന്നു. വളരെ ചെറിയ പൈസയ്ക്ക് അവർ ചെയ്തു തന്നു. ഫ്രീ പ്ലാറ്റ്ഫോം. വിധുകുമാർ സാറിൻ്റെ അടുത്ത് പല പ്രാവശ്യം പോയാണ് ചെയ്ത്. ബട്ട് ഇറ്റ് മിസറബിളി ഫെയിൽ. എനിക്ക് ഒറ്റയ്ക്ക് അത് ചെയ്യാൻ എനിക്ക് അത്ര നോളജും ഇല്ല. അത് പല ആളെ ഏൽപ്പിച്ചിട്ട് അത് ടോട്ടലി ഫെയിൽ ചെയ്തു. 1-2 വർഷം കൊണ്ടുപോയി, പക്ഷേ അത് ഫെയിൽ ചെയ്തു. വാട്ടർ ക്ലൂവറിൻ്റെ ബാക്ക്ലോഗ് ഇടുക എന്ന് പറഞ്ഞാൽ ഹ്യൂജ് എമൗണ്ട്. അതിന് എങ്ങനെ ഡീൽ ചെയ്യാൻ പറ്റും എന്നുള്ള എനിക്ക് തോന്നുന്നത്
3 ഇയേഴ്സിൻ്റെ ഇപ്പോൾ അപ്ലോഡ് ചെയ്തിട്ടുണ്ട്. 3 ഇയേഴ്സ്. പക്ഷെ അതിൽ കൂടുതൽ ബാക്കിലേക്ക് പോകാൻ പറ്റിയിട്ടില്ല. 3 ഇയേഴ്സ് ഇപ്പോൾ അവർ അപ്ലോഡ് ചെയ്തിട്ടുണ്ട്. അതിൻ്റെ ആർട്ടിക്കിൾസ് വിൽക്കാൻ.
The same issue was there also earlier, the shortage of articles. That was there from the very beginning. So that time also we were requesting repeatedly for articles, and that is why it was being, we are receiving articles. But I think everybody should take some initiative to write some articles. And also, I think now, medical colleges are,
index വന്നു കഴിഞ്ഞാൽ പിന്നെ automatically you will get
plus poster publication. So naturally, I think all the colleges should initiate some action to, make the postgraduates to get some studies, and then so that you can get more and more original articles. That is more important. Articles you may get, but original articles are, shortage always. നമ്മുടെ കോൺഫറൻസിന് പ്രൈസസ് കിട്ടുന്ന
ഇതിനകത്ത് ഒരു കാര്യം എന്നിട്ടുണ്ടെങ്കിൽ ഇപ്പോഴത്തെ അവസ്ഥയിൽ സഞ്ജീവ് പറഞ്ഞ വളരെ പ്രധാനപ്പെട്ട ഒരു പോയിന്റാണ്. ഇപ്പോൾ തന്നെ നമുക്കിപ്പോൾ ഒരുപാട് മെഡിക്കൽ കോളേജുണ്ട്, ഒരുപാട് ഡിസീസ് വരും, പറ്റുന്ന എല്ലാ almost all our PG students are our members. All the HODs, guides are our members. Kindly help. കാരണം അതൊന്നും എല്ലാം ഒന്നും നമ്മൾ ഹൈ എൻഡ് ജേണലിലോട്ട് പോകുന്നതായിരിക്കത്തില്ല. സോ കൈൻഡ്ലി ഹെൽപ്പ് Pulmocon to get indexed in DOH, so that നമ്മുടെ ഇവിടെ ഉള്ള ഗൈഡുമാരും PG സ്റ്റുഡൻസും ദയവേത് അവരുടെ ഒറിജിനൽ ആർട്ടിക്കിൾ അറ്റ് ദി ഏർലിയസ്റ്റ് കൊടുത്തു കഴിഞ്ഞാൽ 1-2 കൊല്ലത്തിനുള്ളിൽ നമ്മുടെ ജേണൽ ഒരു DOH ഇൻഡെക്സ്ഡ് ആവും. അത് കഴിഞ്ഞാൽ പിന്നെ നമ്മൾ വിൽ ബീനെ വേറൊരു തലത്തിലായിരിക്കും. പ്ലീസ് ഡു ഹെൽപ്പ്. താങ്ക് യു.
സാറേ, ഒരു സജഷൻ ഉള്ളത്, ഇപ്പം ഇഷ്ടംപോലെ കോളേജസും PGസും ഉള്ളതുകൊണ്ട് എല്ലാവർക്കും ഡിസർട്ടേഷൻ കാണും, ഡേറ്റ കാണും. ഇഫ് യു ക്യാൻ, ഇപ്പോൾ APCCM ലെവലിൽ തന്നെ ഒരു 10 പേരുടെ, ഒരു 10-12 പേരുടെ ഒരു കമ്മിറ്റി ഉണ്ടാക്കുന്നു ഹൂ നോ ഹൗ ടു റൈറ്റ്. ഇപ്പോൾ ഈ റോ ഡേറ്റ കൊടുത്തു കഴിഞ്ഞപ്പോൾ ഡിസർട്ടേഷൻ എന്തായാലും സബ്മിറ്റ് ചെയ്യുമ്പം റീസണബിളി ടേബിളേറ്റഡ് ആയിട്ടുള്ള ഡേറ്റ ആയിരിക്കും. അത് സബ്മിറ്റ് ചെയ്ത് കഴിഞ്ഞാൽ ഈ ഹെൽപ്പ് ചെയ്ത് കിട്ടും. ഫോർ എക്സാമ്പിൾ ഇപ്പം സഞ്ജീവ് സാറ് അങ്ങനത്തെ ഒരു 10-12 പേര് ഒരു ഗ്രൂപ്പായിട്ട് നിന്ന് കഴിഞ്ഞാൽ ഹൂ ക്യാൻ ജസ്റ്റ് ഡൂ ദ ഫൈനൽ കറക്ഷൻസ്. വർക്ക്ഷോപ്പ് ഉണ്ട് സാർ, വർക്ക്ഷോപ്പ് മാത്രമല്ല, ഓൺ എ ഡേ ടു ഡേ ബേസിസ്. ഇപ്പം ഈ കേരളത്തിൽ ഒരു വർഷം ഒരു 50 PG തീസിസ് സബ്മിറ്റ് ചെയ്യുന്നുണ്ട്. അതിൽ ഒരു 45 എനിക്ക് തോന്നുന്നില്ല എവിടെയും പബ്ലിഷ് ആകുന്നുണ്ടെന്ന്. അപ്പം അത് ഈ ഒരു പൾമോൺ എഡിറ്ററിന് അല്ലെങ്കിൽ ആ ഒരു ഗ്രൂപ്പ് ഓഫ് മെൻറ്റേഴ്സിന് അയച്ചു കൊടുത്താൽ അവരുടെ അതൊരു പബ്ലിഷബിൾ ഫോർമാറ്റ് ആക്കാനായിട്ട് വിത്തൗട്ട് മേ ബി ഒരു കോൺഫ്ലിക്റ്റ് ഓഫ് ഇൻട്രസ്റ്റ് ഇല്ലാതെ അല്ലെങ്കിൽ ഒരു റെമ്യൂണറേഷൻ ഇല്ലാതെ ചെയ്യാൻ തയ്യാറാവുകയാണെങ്കിൽ ദാറ്റ് വിൽ ബി ഗ്രേറ്റ്. അങ്ങനത്തെ ഒരു കമ്മിറ്റി ഉണ്ടാക്കാൻ പറ്റുമെങ്കിൽ ഹൂ ആർ ഗുഡ് ഇനഫ് ഫോർ പബ്ലിക്കേഷൻ, ഹൂ ആർ മോട്ടിവേറ്റഡ് ഫോർ പബ്ലിക്കേഷൻ.
അവരതനുസരിച്ച് സാർ പൾമോൺ, I say that we will publish in Pulmocon. Then they will say that നോക്കിയിട്ട് പോരാ. Then many instances I said that no, this should go to Pulmocon, and some people, okay, you send and see. When many a time it is returned that don't worry, this will come in Pulmocon. അങ്ങനെ if there is a will, it is possible. And I have guided many, when must we remember, many papers. You take the count how many. But if the coordinators or in charge, they have a will. I told many of them, because I know some quality. Even if they send somewhere, it may not be public. I tell them, you will go. I expected, and from my experience in that time, we had a backlog of 4 issues. We conducted offered all expense, and only one condition was your paper repaired this way or assisted this way. You have to commit that this will go to Pulmocon.
അപ് ടു ഡേറ്റ് ആണ് സാറേ. അപ് ടു ഡേറ്റാ. ഇപ്പൊ സെപ്റ്റംബർ ഇഷ്യൂ ഉള്ളു ഇനി പെൻഡിങ്. അത് ഒക്ടോബറിലേക്ക് വരും.
സെപ്റ്റംബർ ബാക്ക് ആണല്ലോ.
അല്ല, ഇത് ഈ അസോസിയേഷൻ വന്നപ്പോൾ നമുക്ക് കുറച്ച് ലാഗ് വന്നതല്ലേ.
അല്ല, വേണുവിനോട് ഞാൻ ഒരു പോയിന്റ് പറഞ്ഞു. നമ്മളെ അക്സെപ്റ്റ് ചെയ്ത ഡേറ്റിനെക്കാളും പ്രീവിയസ് ഇഷ്യൂവിൽ ജേണൽ ആർട്ടിക്കിൾ വന്നാൽ DOH തള്ളും. മനസ്സിലായില്ലേ? നിങ്ങൾ ജനുവരിയിൽ ആക്സെപ്റ്റ് ചെയ്ത ആർട്ടിക്കിൾ പ്രീവിയസ് ഇഷ്യൂലാണ് വരുന്നത്.
അല്ല, ഇപ്പോഴും ആ ലാഗ്
അത് ആദ്യം കറക്റ്റ് ചെയ്യണം. നമ്മൾ കുറച്ച് കാര്യങ്ങൾ DOHന്റെ ഗൈഡ് ലൈൻസ് വാങ്ങിയിട്ട് അതിനനുസരിച്ച് തന്നെ ഇനി മുമ്പോട്ട് പോകണം, അല്ലാതെ പറ്റില്ല. പിന്നെ ഈ PG പബ്ലിക്കേഷൻ എന്ന് പറഞ്ഞാൽ അറ്റ്ലീസ്റ്റ് കുട്ടികളെ കൊണ്ട് കേസ് റിപ്പോർട്ടും എഴുതിക്ക്. ദേ ആർ പ്രസൻറ്റിങ് സോ മെനി കേസസ് ഇൻ ഡിഫറെൻറ്റ് ഫോറ. നല്ല കേസുണ്ട്, ആരും എഴുതുന്നില്ല. എഴുതണമെന്നുണ്ടെങ്കിൽ ആ ഈച്ച് ഡിപ്പാർട്ട്മെൻറ്റിലെ ടീച്ചേഴ്സ് തന്നെ വിചാരിക്കണം. അല്ലാണ്ട് വെറുതെ മീറ്റിങ്ങിൽ പറഞ്ഞിട്ട് കാര്യമില്ല. ഓരോ കോളേജിലും ഹോസ്പിറ്റലിലും PG പ്രോഗ്രാം ഉണ്ട്, അത് പറ്റണം. ഞാനിപ്പോൾ എൻ്റെ ജേണൽ ഓൾമോസ്റ്റ് റൺ ചെയ്ത് പോകുന്നത് ഏകദേശം അങ്ങനെയാണ്. എൻ്റെ ജൂനിയർ സ്റ്റുഡൻസ് വരെ കേസ് റിപ്പോർട്ട് പബ്ലിഷ് ചെയ്തിട്ടുണ്ട്. ഒറിജിനൽ ആർട്ടിക്കിൾ അല്ലെങ്കിലും കേസ് റിപ്പോർട്ട് പബ്ലിഷ് ചെയ്തിട്ടുണ്ട്. അപ്പോൾ അതിന് നമ്മൾ ആരെങ്കിലും ഒരാൾ ഇൻവോൾവ് ചെയ്യണം. ഇനീഷ്യലൊക്കെ നമ്മൾ നല്ലോണം ഹെൽപ്പും ചെയ്യേണ്ടി വരും. 2-3 പ്രാവശ്യം വായിച്ച് കറക്റ്റ് ചെയ്തൊക്കെ കൊടുത്തിട്ട് എന്നാലേ അത് കറക്റ്റ് ആവുള്ളൂ. 1-2 എഴുതി കഴിഞ്ഞാൽ പിന്നെ കുട്ടികൾക്ക് ഒറ്റക്ക് എഴുതാനും പറ്റും. അതിന് ആരെങ്കിലും ഇൻട്രസ്റ്റഡ് വേണം
സാറേ. അതാണ് സാറേ ആവശ്യം. ഇപ്പം തന്നെ ലാസ്റ്റ് പൾമോണിനകത്ത് ആലപ്പുഴ മെഡിക്കൽ കോളേജിലെ 2 PGസിൻ്റെ ആർട്ടിക്കിൾ പബ്ലിഷ് ചെയ്തു. അത് കുറച്ച് കഷ്ടപ്പെട്ടിട്ടാണ്. അതേപോലെ നമ്മളെല്ലാവരും ഇതിൻ്റെ മെമ്പേഴ്സാണ്. നമ്മളെല്ലാവരും APCCM ലീഡേഴ്സാണ്. കുറച്ച് പേരും എൻ്റെ രാജേഷ് പറഞ്ഞ പോലെ കുറച്ച് പേരും മെൻ്റർ ആക്കാമെങ്കിൽ നമുക്ക് 1 കൊല്ലം കൊണ്ട് അത്യാവശ്യം ഇപ്പോൾ കുറേയൊക്കെ നല്ല ജേർണലോട്ട് മേ ബി അതുപോലെ ഹൈ എൻഡ് ജേർണലോട്ട് പൊക്കോട്ടെ, എങ്കിൽ പോലും പൾമോണ് ആവശ്യത്തിൽ കൂടുതൽ ആർട്ടിക്കിൾ കിട്ടും. കാര്യം എല്ലാവരും ഇവിടെ പിന്നെ ടീച്ചേഴ്സ് ഉണ്ട്, ഗൈഡ്സ് ഉണ്ട്, PG സ്റ്റുഡൻസ് ഇരിപ്പുണ്ട്. അപ്പോൾ ഐ തിങ്ക് അതൊരു ഒരു രാഴ്ച പറഞ്ഞ പോലെ ഒരു
ഹൈ എൻഡ് ജേർണലൊന്നും പോകില്ല. കാരണം ഇപ്പോൾ ഓൾമോസ്റ്റ് ഓൾ ഇൻ്റർനാഷണൽ ജേർണൽ ലങ് ഇന്ത്യയിൽ തന്നെ നിങ്ങൾ പബ്ലിഷ് ചെയ്യണമെങ്കിൽ ഫോട്ടോ കൊടുക്കുകയാണെങ്കിൽ അതിന് പൈസ കൊടുക്കണം. മനസ്സിലായില്ലേ? ലങ് ഇന്ത്യ വരെ അങ്ങനെ ആക്കി മാറ്റിയിരിക്കുന്നുണ്ട്. അപ്പോൾ നമ്മുടെ ജേർണലിലൊക്കെ ഇപ്പം ചാർജ് ഇല്ലാത്തതുകൊണ്ട് ഒരു ചാൻസ് ഉണ്ട്. പക്ഷേ ആദ്യം മോട്ടിവേഷനാണ് വേണ്ടത്, മോട്ടിവേഷൻ ഓഫ് യങ്സ്റ്റേഴ്സ്. അതിന് ആരെങ്കിലുമൊക്കെ ചെയ്താലും മതിയാവും.
Will solve the problem. Thank you. And I invite the treasurer to present the accounts.